we went for a office also or in institutions where biometric systems are there, and these are like basically based on AI on AI we can say, because it's a like deep learning is a sub part of AI. And so we see that a, bio, a biometric, basically whatever is installed in institution, it is basically consist of a facial recognition they just capture, or a fingerprints and scans. Moreover, in a healthcare also, we just say that wearable devices just track our health activity. And there are a lot of, like you see, the apps are there developed and getting tracking and using the navigation system, the language translation. Moreover, virtual assistants which are available like Siri and Alexa, we generally use. So these are like a real daily life. We use these tools basically. So the idea now, this all the idea has been now been same idea been adapted for the healthcare system, where a deep learning for medical imaging is very important. And through that we know that we can the common analysis like ECG analysis is a very like common terms we used to hear about it. Moreover, we just moving with through this AI in healthcare to the robotic automations also, and through the virtual assistant we are going for managing e-health records, basically we just talk about. So what I need to say that this artificial intelligence is basically reshaping the overall biomedical systems, because what we see in previous these biomedicals, like they are mostly a passive in nature basically. Generally we simply record the data and through the instrument, and then display particular data, and then all the interpretation has been done. So if I talk about AI system, so AI system basically automatically analyzes the pattern, and it highlights the abnormalities which generally occurs in a patient, and then predict that it is risk or not risk instantly. And here you can see I have shown one of the image basically. So it is the application of deep learning framework taken from a paper I just cited here. So you can see that one of the area where AI has made the biggest impact is the medical imaging or a healthcare area, you can say. And it shows that deep learning model are used across almost every organ system, we can say, from brain to the heart to the eye. And here the task which we used to perform in diagnostics basically through this imaging system. So you can see at the right side we have written a segmentation, pre-processing, monitoring. So these are the common key tasks we used to perform basically. You've heard about that. Firstly, we need to acquire the image acquisition, then simply we pre-process the image, and then further segmentation if we want to do, or classification or detection, then we move to the. And for that there are many deep learning models basically. And this revolution basically starts, we all know that with the convolutional neural network, or we generally popularly known as CNN we called. But over time we say that like most of the models has been become dominant, like UNET in medical imaging for segmentation task. And then it came to the mask RCNN. Okay, so further we move to the faster RCN, and also the previous we will just study about its history and all that. So what we noticed there that these all the methods were being used to in certain medical areas, which we see on the right side, like neuroradiology, dermatology, and ophthalmology, breast cancers. These are popular one I can say. And the important thing we need to point out that overall, whatever the AI systems are developing uh, for the healthcare, they do not just generally replaces the clinicians, and it act as an decision support system for the doctor basically. So basically, what I need to particularly highlight that this whatever the imaging we capture basically, and I talk about the ocular ultrasound and fundus, basically two imaging which I will be talking in this session. And so these uh, imaging and what are the important biomarkers in this imaging will provide a first clue to the life-threatening condition, and that will help doctors immediately and help in objective analysis in critical moments. So here in the figure you can see here that in neuroradiology, lot of advancement has been done, and most of the methods like in DenseNet, here you can see here dense. This is the neurology. So here it is showing that how the most of the models are like dominant, like LSTM, DNN are important, and these are some other models has been used for radiology. So it is generally a heat map basically showing everything. So so when I move to the uh, trauma itself, like in neurology, there are a lot of parts, but the common part, like trauma, I'm just discussing in this session. So, among the various neurological diseases, this is some statistics there. That like you can say, in a graph see that there are multiple sclerosis which can be a traumatic condition, or a Parkinson disease. Alzheimer is then people are working on stroke and a brain injury. But according to the Lancet Commission report was there, one of the like study was in literature, and it was found that this brain injury is expected to be among the top three injury related causes for death and disability until 2030. And moreover, there are statistics has been taken out where the number is staggering. Like you can see that 2,14,110 TBI patients related hospitalization were in 2020, and similarly around 70,000. The figure is 69,473 related deaths in 2021. And the shocking thing is that that in USA this figure turns out to be 1 out of 200, while when we talk about the India, this is 1 out of 6 trauma victims are generally dying each day. Basically, I want to say that. So how important is this this traumatic brain injury? And the we can say the major cause for such figure is basically that in India you can say that there is a delay in traumatic brain injury care. And important thing is that 95% of trauma victims in India do not receive timely and adequate care. And if you think about like it's a general way that in a rural area, we take some example, and if suddenly you get some road accidents, so the major causes you can think about it. What are the major causes? The firstly is that if we say that if we got injured like badly, so there is no emergency department we can say, and because of that in rural and remote areas where this lack of emergency department is there, it is difficult to assess trauma condition promptly. Moreover, if let's assume that emergency dependent, but other the things which is there needed, that some skilled person is also not there in the rural areas, and due to which if some person is also available at assume also, but that is lack of specialized skill for accurately measuring the biomarkers which is needed significant for that particular issue. Moreover, when we talk about monitoring, like if maybe in some places if there are emergency department or other things also, but the current process for monitoring and diagnosing trauma condition is time consuming, because the conventional practices which are there, that are for trauma cases are invasive in nature. And what do I mean by invasive? You already know that that invasive like techniques which are there, that are very high risky, and it is the equipment which is associated with it is costlier. Moreover, so what I can say that there is non-availability of automated system, and if all these things are delayed, then you see the person which who got injured in the road accident in some village or somewhere, and all these things are not there, then by the time he reaches somewhere to the hospital, it is too much delay, he may lost his life. Okay, so this is the main cause, what I can say, that is creating that figure, what I told you about in India, it is 1 out of 6 trauma victims are dying that we compare with the USA, basically. So to address these particular challenges, the potential solution, what I found, is what I told, that we need a system basically that should be a computer assisted system or detection system with the implementation of AI, where we can say that medical imaging for trauma care facilities. This is where we combine this artificial intelligence with the ocular imaging, that it basically, we can say, will provide a faster, safer, and reliable trauma assessment. So if I move to the CAT system, basically, so you are also are familiar, I think, with the CAT system. I will not go in much detail. So generally, CAT system offers our decision support to the medical professionals, basically, or the peoples are there, and it does not replace the radiologist. And moreover, there are several examples we can see, like in cardiac diseases. There generally CAT tool play a very important role. Moreover, in eye diseases, where we diagnose cataract, glaucoma, NDR, basically diabetic retinopathy. Moreover, in lung disease also. So in trauma care, CAT, this computer aided diagnosis system, has a great potential, basically, I can say, that can provide a timely assessment, especially when every minute matters, basically. So by integrating this overall computer CAT system in ocular imaging, uh, we can have benefits for such patients, basically, and for diagnosis. So if I talk about brain, this traumatic patients, basically, so this suffers from a brain injury, basically. So basically, we see that there is a major cause of this brain injury, and it basically occurs due to sudden and forceful impact, which happens on a head, or which disturbs the brain tissue, basically, we can say. And it is a figure are there that most of the accidents are happens because of like motor accidents, vehicle accidents are 21%, and the object, something is struck in your head. And moreover, like old peoples are there who are falling through the staircase and they get injury at that time. And due to the age factor also, we cannot generally get assessment like in a quickly way. So this creates this life threatening injuries should need to be identified properly. Moreover, there should be proper management, so that briefly report as soon we can generate and provide. So the important picture here is that for this traumatic brain injury, the important parameter which I want to highlight is the intracranial pressure, which is in the brain. It's like a pressure which builds up in the brain, and we need to monitor this for patients with severe TBI patients, we can say, basically. So when I talk about the role of intracranial pressure in a brain injury, so according to theory is there, Monroe Cayley, where he has suggested that this like the cerebrospinal fluid and the intravascular blood and brain tissue, these are in a equilibrium position. Okay, so if one of some like brain tissue is disturbed or intracranial blood, then this pressure starts to build up, and this generally affects the brain tissue. And the major cause of this, that CSF fluid, that is cerebrospinal fluid, generally used to build up inside the brain. Okay, and if we talk about the normal range for the measurement of this ICP, so it is measurement in millimeters of mercury, and the normal range ranges from 17 to 15 mmHg for an adult. And what I talk that if in a brain, if this three components has been disturbed, basically, so that will create a pressure, basically. And if this pressure exceeded the 20 to 25 mmHg, so we need and treatment basically to reduce this ICP, intracranial pressure, basically. And the available techniques, what I say, is the invasive measurements are there and a non-invasive. So you all know that invasive measurements is like when we performed any cutting or something like into the skin basically, and and through that it will create complications, and this is not, we can say that suitable for routine checkup basically, and repeated measurements we can't do. Moreover, when we talk about non-invasive side, so it does not require any skin breaking, and it is safer. What I talk about in this the imaging part, that we can use ocular ultrasound, fundus, or MRI, or something is there. So that is a non-invasive part. So when I talk about invasive measurements, so it consists of basically two popular gold standard. One is like catheter insertion and a lumbar puncture, we can say, where the catheter this when I talk about catheter insertion, so catheter insertion is basically done in two ways: intraventricular or extraventricular, uh, basically. So when I talk about interventricular, extraventricular, that is a particular area we are particularly working out. I will not go in much detail, but uh,
சும்மா வந்து ஏமா
initially,
நான் வாய மூடிட்டு போயிடுறேன்.
how we measure this basically, whenever we need to do some measurement for ICP, we need to drill that particular brain through a drilling machine, and then insert a probe basically, and that particular probe is connected to a pressure device basically. And whenever we just get out that fluid basically, and we used to monitor that pressure, that we are taking out the fluid out. Similarly, in lumbar puncture, what we do, instead of brain, we used to generally at the back of the spine, we need to take the fluid through the spinal, that needle part, we can say. So these are very risky, you can say, the invasive methods. And the current methods which I talk, like non-invasive techniques, we are moving there, like a CT scan, MRI, ocular fundus imaging. So the advantage of ocular ultrasound here is that it is portable in nature, and moreover, it allows for real-time imaging of the eye, so that patient can be treated at the bedside. Moreover, if we compare with the MRI and CT scan, so with MRI, we can say that it does not require ionizing radiation, this ocular ultrasound, and it is safe for repeated use and assessing structure like retina, like part, and if we talk about ocular one, and an optic nerve basically. Moreover, fundus imaging is an alternative part, which also focuses on such key areas like retina, optic disc, and blood vessels. Okay, so but these two are ocular ultrasound and fundus imaging. What I say, that is a much safer there, but people are working in all the four areas like CT, MRI, ocular, and fundus imaging. Okay, so this is the where I show you a imaging where a diagnostic biomarker has been captured. Okay, so you can see here that we have a probe basically. Okay, so sorry. So a transducer probe, we can see, is placed gently over a closed eyelid, and whenever we capture in a real time in a hospitals, we used to place a gel over there before placing this this ultrasound probe basically. And it generally works on the principle, as you know, on the sound. Okay, so when we place this, we capture the anterior chambers and the posterior chamber basically through this ultrasound probe in an eye, and also we reach to the retinal part and the optic nerve region basically. So here you can see another figure, which is an ultrasound image, and I want to highlight here that two important biomarkers are there, like optic nerve basically here, and eyeball transverse diameter, which is there. Two basic biomarkers, which is very important in measurement, or you can say in prediction of this intracranial pressure whenever it raises, basically. So let me go into much depth. So if I talk about an optic nerve, basically, so basically, and this optic nerve, I can say, generally is protected protected through three protective layers. That is a dura, arachnoid, and pia mater. What you can see here in figure A. Okay, so here you can see that this is the optic nerve area. If I take some one circle, then the subset, the like another part is pia, and then subarachnoid, then arachnoid, and dura mater. So this is a biological one. You can go in much depth in this. So when I talk about this optic nerve area, so in next B you can see that whenever this is the normal condition where I talk about the range, basically. So I talk about the ICP range, which was 7 to 15 millimeter of mercury. But in the case of a person, if adult needs to be have normal range for optic nerve diameter, it should fall within the range of 5 mm, below 5 mm, or at the border of 5 mm. And if we go beyond like 5, so 5 to 6 is considered to be the moderate, and exceeding the 6 mm considers to be a critical conditions where we need again a treatment, basically, like regular monitoring of the patients. So here you can see that that whenever this fluid has increased there, that is a CSF fluid, so this optic nerve area has been dilated. So it has expanded, basically. You can see this particular in this area. So because of this, what happens that in a brain, because of this pressure, the person mind does not work, basically, and it may create a hemorrhage, basically. So here you can see generally in an ultrasound image where a doctor, so this is the part what I previously talked about. This is the eyeball, and this is the optic nerve, and the expansion part is like optic nerve diameter. So you can see this is the normal part, OND, and then where there is expansion, so this is ONSD we are talking about. And whenever we used to measure this, generally a doctor used to measure. So he used to measure through this retina part, and through there he perpendicularly draw a line, and then 3 mm, basically, and then through that 3 mm below he will used to measure this OND or ONSD diameter, basically. So this is a very important parameter, and this also has uh, like I can say clinical importance with the ICP. So next parameter which is there is the eyeball transmitter. This is a important parameter because lot of like automated study has been not done, because in recent years for optic nerve, basically diameter measurement like automatically since 2019, what I say. So there are also not much literatures or something like work has been done. Still the work is going on, and the major problem is the data availability, basically. But recently from 2023 you can see that people are now giving the data, basically. So this eyeball transfer diameter, what I am talking, the next biomarker. Okay, so this you will not find in most of the like this type of you can say imaging, basically, to measurement there. And this is important because in most of the literature has been highlighted that if you take the ratio of this optic nerve sheath diameter and eyeball, so it will be much beneficial to relate or correlate the things with the ICP, basically. Okay, and the important thing of this that it generally when the patient, that in adults, basically, that if adults is grown up after some age, so this eyeball diameter does not vary much, and it differs like 1 or 2 millimeter. And if I talk the average measurement for this for the I can say for the patients, basically adults, so it is 23.7 mm. Okay, it may vary to from 21 to 24 also, but the average one is 23.70. So this what I said, that eyeball transfer diameter is a very important, and like it will play an important role in developing the ethnicity among the patients. because when you see that if you see patient with a different age group, like a Chinese people or Japanese, their eyes are similarly different, and their eye wall maybe sometimes like have different size basically. So that variation basically to solve that, to go through that variation basically, this eye wall transfer diameter is very important biomarker. Okay, so what why we need this biomarkers basically? So to develop an automated measurement system, so to monitor the intercandical pressure in traumatic conditions. So the important thing is that uh, to measure this ICP, we need some clinical biomarkers. So this ONSD and ETD plays a very important role. Moreover, if we talk about this measurement, what I talk about, the doctors is doing, measuring perpendicular 3 mm and then getting the measurement for ONSD. So uh, the machine which are there available in the ocular ultrasound, it uses the electronic caliper basically. So it has certain limitation. Moreover, if you see that are operator independent, so we uh, can't get the actual points basically during the measurement. So these are some basic some challenges which there in a real scenario we can find out. So uh, this tells us that we need a real time system that should be automatically, and it should not delay the basically treatment and for the patients. So here you can see the video is playing, where you can see the most important challenge is that what I talk about, that the patient, the persons who are there, it is not skill. So this was captured a video file at this Jayaprakash Narayan Apex Trauma Center in New Delhi, where you can see, if I play, so if I play this video, you can see we are placing the ultrasound probe on the patients. These are trauma patients, and so we are capturing this image basically. You can see here. Okay, let me play this video, first video. Okay, so you can see that during this capture of the image, so the this lot of images were generating. Okay, and you can see that this optic nerve area is not constant. It is varying with each image, and in some of the image, if proper gel placement is not there or the person is not scliced, so it will be very difficult to capture a good image where we can get the measurement of the biomarkers, which I talk like optic nerve sheath and eye wall transfers basically. So that two biomarker is very difficult to measure through such image, and doctor uses to face challenges because he can't capture this like if he captures that particular image also, but if it is not good, the parameters may change. Okay, so the important task challenge is to firstly, if you get some video files are there which having a multiple frames, so we need a good frame basically, you can say, to get that good frames for particular steps for measurement of optic nerve and eye wall transverse diameter. Okay, so you can see that lot of training is required here for the clinicians when we are trying to get the image acquisition. Okay, so this was the main challenge what we say. Okay, so because we are with the touch with the AIMS department, and we are working, and so this all the problem has been given by the doctor which is there. It's Professor Deepak sir, Deepak Agarwal, who is a neurosurgeon there. Okay, so next, what I talk after this challenge was there. The another challenge with this ocular ultrasound image is the manual measurement. What I talk like with the help of electronic caliper, what we are doing, like uh, getting the like two boundaries basically. So what you see that the measure like firstly challenge was that whatever the image we acquired, it is good or not, we need to capture again. Moreover, with that, it may have limitations like of measurement also. So this is not feasible for regular monitoring because it has also some like guidelines that 5 to 10 seconds only can be placed on a trauma patient. Beyond that, we can't capture such images. So again, if we are doing that thing, then it will harm the patient's brain basically. So moreover, with that capturing of the image, so the thing is that we need to determine the exact boundaries basically, and that can be obtained when we get the relevant features from the optic nerve sheath diameter. And moreover, the biomarkers which are there, we can't say it is like normalized or globalized, because if if you see the if you study the literatures, this ONSD and ETD varies very much basically among the patients, and ICP has the correlation need to be developed basically. So we have another parameter with ONSD was the ETDI was transverse diameter, and this was the like the fine image which we obtained. So you can see that around 429 like frames are there, and some frames are good, some frames are black are coming. So among these all, we need a frame which have a better view of optic nerve and eyeball basically. You can see that at this top of the boundaries are not clear, and all we can say that it will generally it's a very difficult challenge to solve this problem. Okay, so when I move, so the proposed solution we found, and that using existing CNN architecture, which I talked at the faster RCN. The idea was to choose this faster RCN because in medical we can't go for a one stage detector. We need a two stage detector, so we can. The accuracy is more important than the timing is also there for getting good results. So basically, whatever frames was there, we obtained through this video files. We extracted the particular images, and then generally we marked with the help of a clinicians the optic nerve area, and through that we trained those imaging, and then proposed some grading scale and further done the validation to verify this optic nerve detection and measurement part. Okay, so this was the like faster RCN method which we generally use there. So generally it works on two stage layer, like reason proposal and reason interest pooling there. So I will not be going much in detail. So here we detected them. Moreover, we use the like transfer learning weights basically to get the feature extraction from that particular the learned features, and then using the features which were
Excuse
extracted.
me, sir. Sorry to interrupt. Can you please go back to that previous slide that you just skipped?
Okay, sure.
Previous. Okay, this one.
Okay.
Is it RNN or something different?
No, it is not RNN. It is faster RCNN, regional convolutional neural network. It is different thing. RNN is different. RNN is
Okay.
uh,
Recurrent neural network.
yeah, it is faster. It's an object detection model, which you say. RNN works on different principle.
Okay.
Okay.
Yes.
So,
Thank you, sir.
okay,
Sir, please show previous slide. Previous to the.
okay. This one.
Sir, hold 1 minute.
Is there any question? Hello.
So you can continue, sir.
Okay. Okay. So this is the what I talk about the fast RCN methods. So do anyone need to explain this in detail? Because I think this is a generalized one now. People used to know all these things.
So it would be better, sir. Please explain.
Okay, so in this, what I say that this works in a two-stage process. So here you can see in a figure basically. Okay, so this is the ultrasound image, and what I talk about that we done the labeling part. Okay, so labeling we generally know that in object detection wherever you are performing faster RCN, or most of the people are now familiar with the YOLO network also. So they used to have some rectangular, like you can say what labeling we used to do in particular areas. So this was done with the help of an clinician, the staff which was there in the AIMS department, the optic nerve area. So After getting those particular this, we pass through a convert layer. This is a convolutional layer where we use a three model. Basically, we use for testing Inception and ResNet. In ResNet also we use ResNet 50 and ResNet 101 model. Okay, to extract the feature. So passing the input image, this firstly through this I can say through this convolutional network, and the bounding boxes which we have created, the information which passes through this particular. Okay, and based on some predefined grade system, we generate in a bounding boxes. So this information was coming like image features, the bounding box information, and then we are generating some proposals from the features. Okay, and these generating bounding boxes are of different sizes, I can say, and aspect ratio. Okay, as you can, the fast iteration method says. Okay, and these bounding boxes are mapped as a feature map. Okay, and then there is a regional proposal layer. Where is my, okay, so this is a proposal layer where these bounding boxes are generated, and using this extracted feature we refine the coordinates and scores basically for predicting the likelihood of the optic nerve sheath, because you can say uh, whatever we have the like four axes now. Here you can see there's a four coordinates basically information there. Okay, and whenever we are just predicting the score, so we will be using intersection over union information. I will be next slide, I will be showing you. So here after generating some bounding boxes, because these are of different sizes and aspect ratio, so we need some fixed number of subregions basically. So we use the ROI pooling layer, which is a region of interest layer. Okay, that divides each proposal into a fixed number of subregions. You can see here. Moreover, this step is used to ensure that we have a uniform size, allowing the next stage to process them efficiently. Because if different sizes are, that will be very difficult. Okay, so so the idea of this layer ROI is to get a uniform size, and then we use a softmax classifier. Okay, to classify those regions to identify that the optic nerve sheath is present or not there. Okay, moreover, if we got a score of 95%, like detection score, so we say that it is a good frame basically. So you can see here, this is the next slide which I talk about, where we get accepted feature and processing through, sorry, processing through two fully connected layers, that is layer 1 and layer 2. Layer 1 has been getting information about the bounding box prediction. Moreover, layer 2, like classifier we are doing and the probability we are obtaining. Okay, so this is the formula where we say that it is good or excellent when we have this area. So the overlapping is good, then it has in very good if it is like the with the ground truth, I can say the predicted one and the ground truth, the overlapping which are having. Okay, so this is the main idea there for getting a good frame. Moreover, with this, we also proposed, you can say, this grading criteria. Okay, where we have four criteria like overlapping windows, and if the detection score is less, basically 55%, then it is unexpectable. Moreover, the labels which are there, which are not like well classified, or the boundaries are not clear. So you can see here the five cases are there for quality. That is, first was unexpectable, that we cannot expect that if something is happening, then that detection score is 55 to 85%, it's considered to be poor. And if it is close to 85 to 99%, okay, and this you can see the windows are differently coming. The one is showing 86% or another showing 9. So if it is there two overlap windows there, then we are not allowing those window. Okay, so we are rejecting those images basically as a good view. Moreover, the perfect one, we so that it is like good and excellent, we consider these two cases where if the score is 96, like 95% above or 99%. Okay, so this was the 4 and 5 score we have chosen. So moreover, the data set we collected, that I've shown you the video from collected from the AIMS center, And we use for the initially for the 51 patients, we capture those video files, and we have lot of yes, like images there. So for training, we used like 17, 19 samples and 80 for testing basically, and using the Adam. And then we obtained this loss functions basically, which is of bounding box and localization loss. Two type of losses were there. Okay, so we calculated for this inception V2 model ResNet 50N1, and then we also obtained crucial parameters like sensitivity and specificity, what I called. Okay, so this was the grading criteria, and these are some results we got. Okay, for different patients basically, and then we done the subjective evaluation. We have two researchers basically, and four clinicians was there for such obtaining the mean opinion score. Basically, we consider for different cases, and whatever detection score we obtain, we get the opinion of like manual opinion from the peoples, and then finding the mean opinion score basically, and then correlated this with the generated and detection score what they are doing. So we got a correlation coefficient of 86 for the best score, which we considered like in the range of 95 to 99%. Then so for further measurement of ONSD, and here you can see that the good view score was calculated for different subjects, and then we have manually measured from the doctor side and automatically measured in the difference basically. Okay, and then we compare those results and determine the percentages root mean square difference also. So if for 95 to 99 score, we get a good mean opinion score for the two clinicians and the two researchers, and a PID of 0.51. Okay, so based on that, whatever good view frame I got, we then moved out frame for further pre-processing and the automated measurement of ONSD and ETD. Okay, and then the idea was to predict the raised intercandical pressure is present or not. Okay, so here you can see the full block diagram, which I have shared here. Okay, so after getting this good frame, basically we process for filtering operation, and then selected the like reason. I will go next slide where I discuss with each step. Okay, in filtering operation, we use the median filtering basically. So in a median filtering, basically the idea was there because we don't want to remove both of the artifacts basically, or the information which is there, because in medical imaging, like we do a lot of filtering, then information may, the important information will not be there. Okay, so simply we use the as ultrasound generally during acquisition have salt and paper noise basically. So we use the median filter, which is best to remove that. And further that lot of area you can see here is a redundant one, this black part. So we selected this particular region basically, okay, as a region of interest. And moreover, the idea was to identify this particular area, this optic nerve area. So we finally use the contour operation to get this information, as this eyeball information, which see that it will be helpful for this ONS optic nerve area. Okay, then with this fitting, we extracted the optic nerve. Okay, and then we got this plotted this some after getting this, you can see the optic nerve area. We have generated an parabola like shape. Okay, and multiple parabolas were generated, and we varied three basically parameters like the focus of the parabola, and moreover we are changing the centroid position and the orientation of the nerve axis. And with this orientation, like with these changes, we obtained multiple parabolas, we can say. So the figure was like we calculated some figure. It was 625, and then we measured the ONSD and ETD. Okay, and then this is a statistical which we get from analysis from AIMS, the 0.21. Hello. Hello. Okay, so this was the like statistical parameter obtained, and then if it is greater and less than, so we predict the raised ICP. So these are the some you can see figures and the detailing part procedure which we obtain, like median filtering we use, and then we get the region of interest and perform particular advanced image processing like morphological operations and thresholding using the contour operations, and then fitting the ellipse for doing the masking part, and then extracting this through auto-save binarization, because it was like selecting a manual one is not good, and so we selected the auto-save binarization. It gives good results basically in our case, okay, in identifying the particular boundaries of the optic nerve area, and we identified the centroid part. Moreover, this is what I am talking about, that this optic nerve axis has been drawn, and since I talk in the initial part that through this yellow part is this the optic nerve tip region. Okay, so this tip region we used to draw perpendicular line and used to measure this measurement basically. Okay, so the idea was to first to get this particular region, because as I talked in at the initial point, that with the pressure, what happened, this optic nerve used to dilate basically. In a slide I told you. Okay, so because of dilation, what happens, this area, if I talk about, it is like get dark and light transitions basically is there. And most of the areas, like if it is expanded, there will be a dark area. So to get the good like a particular region basically, so we draw multiple parabolas, and then we also plotted for each parabolas the intensity summation. Okay, so this you can see, we plotted for each para intensity summation curve, and wherever we get the maximum, this negative peak, the this is the one, the parabola which we are getting, so that we selected as the best for a parabola. Okay, so this is, you can see, we plotted with a yellow line. Okay, the best one, which is the negative peak we are getting. Okay, and from this we just through equilibrium distance we get that 2 points pointed out, and then at 3 below we find this optic nerve sheath diameter range basically. Moreover, the another parameter which was there, like eyeball transmitter. So we have used the circle fitting basically, getting those particular area and keeping in mind this particular region should be there, not exceeding this region. So we obtain this measurement also, and then this is the observational parameter we then. So the age group which we obtained is in the range of 18 to 70. The patients was there, and we compared those results with the manually and okay. So moreover, again we kept correlated with more data, and we obtained hello. Hello, hello. Okay, so we obtained a correlation value of sir, can you mute the hello?
Please
Okay.
continue, sir. We are listening.
Okay, so we obtained a correlation value like 0.8 and some for this relation we have obtained. So we obtained with the ONSD alone an ICP relation where we obtained 6.9 particular value, and we are considering the the ratio of ONSD and eyeball transmitter. We got the relation like 0.81 correlation value. So this parameter we found that much better for in predicting the raised intracranial pressure. Okay, so this is all the statics things we obtain with the data which we get from the AIMS department. So the threshold was defined like 0.21. Okay, so this is some validations we have done with the manually data we obtained, and sorry, with the automatic one. So here you can see that for the two samples I've shown here. Okay, so moreover, this is a summary that we get two biomarker which is very important in predicting the raised intracranial pressure. Moreover, the method which we used is a for ONSD measurement ETD is an advanced image processing techniques. So like in now a lot of people have started working with the deep learning as it comes. So people are working on, so I suggest you all, if you can work on it using deep learning for obtaining this optic nerve sheath diameter automatically and ETD. Okay, so this is the overall integrated algorithm which we have obtained, that getting a good view frame and the algorithm, and then after some time we will obtain this good frame then ETD value, and it will be representing that for what ICP level we are considering as a REST ICP. So this all instrument we implemented on a Raspberry Pi basically device. So the difficulty was with uh, the timing part, because execution time was like very slow for this. So we use NVIDIA also, that was performed very well. So we whatever the system we developed there, this through this algorithm and implemented on an Raspberry Pi and NVIDIA. So we done the real time this implementation by attaching this system to the ultrasound console machine which is present at the AIMS, and also we implemented the cloud based implementation. Okay, so this is the like overall implementation of our system, like the technician will be there available, and our system will be connected to the ultrasound console machine. Okay, and capturing the image will generally be there, and during the in a real time, if with our algorithm which are there, through that if we get a good view frame, then it will highlight that the frame is detected, and it will process for further measurement of this ONSD and ETD and calculate a ratio, and then we will say that the intercanalicular pressure which we obtained is a raised or not raised basically, and that information will be translated to the local expert, and moreover this diagnostic representation will also be go to the remote centers basically, okay, through cloud based. Okay, moreover this was the cloud based implementation we done through S3W bucket. Okay, so using those bucket we generally like get the data uploaded to the AIMS in a particular data bucket basically, and our algorithms was like connected through the center, and then we used to process those data, and all the results were calculated to the algorithm, and the information reaches to the clinicians like doctors, and then he can recommend some consultations basically. So these two type of implementation we basically do for prediction based ICP. So this is the setup we basically I show you for Raspberry Pi. We obtained running these algorithms. Okay, so this is all. Then we done the validation part through this cloud form also. Okay, so the same like comparing the values with the whatever the operators we are having, two operators we used here. Okay, then we obtained some for the system like what is the accuracy and all that. So we are generally
Sir,
getting.
can you please show Raspberry Pi slide?
Okay, sure.
Raspberry Pi.
Yes, ma'am.
Okay, sir, just 1 minute.
Yes. Any question? Hello, ma'am. Any question from your side?
No, sir, actually, I just wanted to note down. That's why.
Okay. No, actually, we use the model B basically. Now the new models also came like 5 and all that.
This is
Okay.
the hardware part, no? Raspberry Pi chips.
Yes,
right?
sir. This is the hardware part. Okay. And this
And
we
it
have
is
a.
used for that sensing.
No,
Sensing.
actually, yes. And the data which we transfer, that it will go through it and sense all the things.
Okay, sir. And sir, please share your email ID so that we can reach you out.
Okay. Okay. I will sure share with you.
Yes.
Okay.
Thank you.
So this is the like initially when we started work, we work with the Sonosite machine there, and later on we moved to the Sonosite, that is different machine, that is H2, and we validated the performance with this machine also. and we are getting good results basically. Okay, so accuracy for overall system we obtained like 90.3%. We obtained, not good we can say, but it is like we can say that it is as an initial stage good one. Okay, moreover we obtain sensitivity like for abnormal cases like 92.37%, and for correctly like without raised ICP we have got 85.41. Okay, and we also obtained a kappa score where we got 0.77 for predicting raised intercandical pressure. So this is the ROC cycle. Moreover, I need to also focus on this fundus imaging, which I there, because the key, the idea is to tell you this because ocular ultrasound is popular one. Okay, and fundus imaging, what I need to say that is an alternative one because you can say that a lot of people are working on this, and it has been explored for glaucoma like diseases, cataract, diabetic, it's like different stages we can say. But for monitoring of intracandical pressure, this fundus image has less explored basically what I say. Okay, and there are several parameters like people used to do segmentation of optic cup and disc, and then they diagnose glaucoma. Okay, but the important parameter which can relate to the ICP is the artery and vein. We can say the blood vessels which are available there, and the normal range for healthy patients is it's in the ratio of 2:3. Okay, that is a artery upon vein ratio we can say. So it's something value can 0.63. Okay, so if it is less than 0.5, like the ratio is 1:2, then the patient like a mild hypertension conditions will be there. Okay, similarly, this optic cup and disc ratio is also there. Okay, for healthy, sorry, for healthy adults, it's ranges for 0.3 to 0.5. And if it is less than 0.25, the hypertension exists basically. Okay, so this is a very important area which has not been explored with a lot of the people. Okay, and people are working only on the glaucoma, cataract, and this thing. Okay, so this intracandical pressure we can start with. You can if you have some data and all that. Okay, and this is important because this intercandical pressure, as you know, that it's in the brain basically, and it also affects this artery and veins. Okay, instead of what I talk about the recent through ocular ultrasound, the optic nerve and ETD basically. So these are other biomarkers which you can explore. So this is a simple biomarker lessons you all know about it. I think a lot of people if we are working on it. Okay, so I will not go in much in detail in this. Okay, so the challenges is like in artery veins. The important part is that veins play a very important part. Okay, and it is very crucial. Moreover, whenever a lot of people have done segmentation, also working on artery veins, but the challenge lies in the extracting the thin blood vessels of those artery and veins is very important, which generally leaves, and that may create complications later on. Okay, if we did not diagnose properly. Moreover, for monitoring of ICP, you can explore these biomarkers. Okay, so we have also get an algorithm on this for automatically predicting the artery and vein. So we done the pre-processing simply normalization and using our two different deep learning network, basically the existing one, and then extracting the artery and vein information. Okay, so and then we done the validation part. So we did not generally we are working on it basically for monitoring of ICP. Okay, so I will move out. So this is a normal steps which you done for pre-processing, and then segmentation went then to the efficient network and unit as a decoder. So it is a hybrid model we basically use with the efficient B7 and unit. Okay, to obtain this artery and vein. Moreover, for optic curve disc, we use the existing this DCG net, and then these are the some steps which we involved, like selection of blood vessels and then pre-processing of vessels. Moreover, we targeted the important regions and then determine the vessels area and diameter. So we have done some hyper tuning with this. We use a three type of data set like RITE, HRF, and LES for segmentation. and DrishtiGS, and there are other also, again from DrishtiGS you can see there are refugee, rim1, other dataset, but we worked on the DrishtiGS for optic up and disk, and this is all set up. So this was the performance we evaluated basically uh, with the diagnostic biomarker, where we obtained a good sensitivity and specificity. Moreover, we have done a Bladman plot we have done, and this is the, again we have done the manual measurement. So we compare with the data set which is the is there a inspired, is there when some data set is there. So we worked on that and validated the algorithm. I could not recall here. Okay, but we validated with that particular data set because that is the only data set available for 40 patients, and in that they have labeled the value for artery win ratio basically. So when we worked with other images and compared results then with those manual one, so where we obtained an average error of 0.15. Moreover, I want to highlight this, that the tool which we use, because the data which we obtained is in the form of DICOM files. So we use the DICOM software basically in extracting the information and other things also. So I want to just highlight this. If someone are familiar, they can work with this DCM file format also. Like people used to convert those in PNG and other things, but the DCM format is a very good one. Okay, so that's all from my side. Okay, hello. Is there any question now till now from your side?
Any question, please?
Excuse me, sir.
Yes.
Sir, in one of the slides, you have shown some p-values. So that p-value is meant for which hypothesis test?
Now where I'm, yeah, just tell me.
Some p-value you had shown. Is that for hypothesis test or something else?
So for statistical, we have done basically. I think you're talking about p-value here in analysis part. We have done
Yes,
here.
statistical analysis.
Yeah. Okay. Yeah, we for statistical analysis we have done hypothesis part.
So that which hypothesis test you have used? Sir?
Actually, I could not remember that. Okay, because some other people are working with me. Okay,
Okay.
but I will let you know.
Okay, sir.
Okay, moreover, I want to also let you know that this data which I am having, okay, is an like you can say we can't share with everyone, like if you're asking with me. So if you want to really work on this there, so recently you can just this link is there, this public data set is there, so you can download this. This
Can you
link,
please type it in the chat box?
yeah, I will share you this
Copy
link.
paste.
Okay, I will just share this link. So you can download this data, and there is also manual values are there, and then you can work out on particular things, deep learning models also. Okay, just a minute. In the chat box. Okay. So I've shared with you. So
Thank
if
you, sir.
anyone wants to work on it, they can start working with this. Okay. Okay, so any questions? Hello.
Any question?
Because I left 15 minutes for question hour.
Yeah.
Sir, how's the edge detection system works, sir, in your slide that
Just a minute. Here you are talking about?
previous slide, sir?
Just a minute.
No, next slide, sir.
Okay. Here?
चांद देखते हैं, फिर दूसरा
Yes,
चांद देखते हैं, फिर
5.
तीसरा चांद देखते हैं।
V.
Hello.
2 महीने में 3 चांद देखते हैं, लेकिन रसूलुल्लाह के घर में आग नहीं
Yes, sir,
जलती।
this one.
मैंने कहा
Yeah, this one you're talking about, na?
No, previous one, sir.
प्रिंसिपल होता था।
This one?
Yes, sir. The point V point, sir, 5 point. Extraction of optic nerve system, sir.
Yeah. So what happens? So, sir, can you repeat?
मेरे बहन जे हम एक चांद देखते फिर दूसरे चांद देखते और फिर तीसरे चांद देखते
Hello.
2 महीने
Sir,
मेहनत
can you
की
mute?
लेकिन रसूलुल्लाह सल्लल्लाहु अलैहि वसल्लम के घरों में आग नहीं जलती थी मैंने कहा साला जान फिर
Hello.
आपका गुजरा किस चीज पर
Dear
है
participant, please mute.
उन्होंने फरमाया 2 खाली चीजों पर यानी फजूल और पानी पर
Hello.
Any question, please?
Yes, sir. So this is not the actual one. Okay. What I'm talking about. Okay. So what happens that in our process, like this was the core area. Okay. And this optic nerve was the reason which we need to extract. For that, we have done this ellipse fitting, and sorry, here when we use what we are talking about the edge detection, so we use the autosol binarization because if we also done that thresholding also to detect this edge part. Uh, for that, it is not like properly extracting those information the key boundaries basically, but auto says that it's work on different principle. So uh, it has a like a good like extracted the part of edges part. Moreover, this is also not a final part. We have the edging we can say. So for that we perform this parabola operations here.
Okay, sir. What is that blue one, sir, in the middle?
Blue one where?
Yeah, that extraction of optic nerve. That slide, sir, only. Yes.
This
Yeah, the middle one, the blue dot.
that is the centroid of the optic nerve.
Okay. That is
Because
defined by you, sir, or detected by system?
detected by system.
Okay, sir.
Because that is very important, because what happens that when we used to find this reason, so basically we are interested with the centroid area and the centroid of the globe. This region is used to called as globe. This eyeball also, this region used to called as globe. So why we are interested? Because what I told that this centroid and this centroid we used to draw a simple line. We join this particular two cent globe detection and this optic nerve centroid, and to vary the parabola basically what we done, we vary the focus of the parabola and shifting plus 5 like plus 10, you can see plus 5 to the right side to the centroid, and plus 5 and plus 5 to the right side. So we get 5 different positions basically, and on that 5 different positions we draw this parabolas basically, so that we can get this when this optic nerve used to dilate basically, so we can get the particular key areas. You can say like here you can say we have done, we have just, you can see this figure is there, just zoom it. Okay, you can see here, no, this is the centroid we pointed out, and then through the centroid to plus 5 minus 1 we have other points we have this get the distance moreover to this side, and then draw based on these multiple parabolas, so we can get the exact the boundaries of the seat basically.
Okay, thank you, sir.
And moreover, this you can see this was plotted like uh, since you can see this is a very dark part, and when you come down like we done the raster scanning operation also through this area, like performing like left to right operations, and whenever we got this particular area, because this is the retina part. Okay, so in this retina part, whenever we get some like informations like some pixel values, so we used to point this as a this yellow point optic nerve tip, we used to call this optic nerve tip. So this is helpful when like through this when we draw the parabola and through the two boundaries like this and this are the 2 points. So if I need to measure this now, where I want measure, so from this optic nerve to this yellow part, we will come down perpendicularly 3 mm down, and then to that particular point we will select this yellow one, and measure the ONSD value. Hello, is it
Sir.
okay?
Yes, yes, sir. Thank you, sir.
Any other question?
Any other question?
I think no question, sir.
Okay, sir.
Okay. Thank you, sir. Thank you for a valuable talk and very good interaction also with the participants.
Yes, sir.
And
Thank you
it is
also for inviting me for such
yes,
a
sir.
beautiful sessions.
So in future also in our next program we'll invite you most
Yes,
probably.
sir.
Okay,
Yes,
sir.
sir.
Thank you, sir. Thank you very
Oh,
much. So dear participants, just after just at 7:30 we'll start the next session. Please leave now, sir.
sir. Okay, can I leave?
Sir, excuse me, sir.
Yes, yes.
Sir, actually, what are the different types of biomarkers used in this field?
No, basically, when I talk about, see, in a medical, there are a lot of biomarkers. First thing is you need to clear. And second thing, in which key area you need to work out. So if I talk about in my case, when I talk about the trauma patients, so I'm working on the ocular ultrasound image. So in that ocular ultrasound image, the two key biomarkers which I focused on, the optic nerve diameter and the eyeball transfer diameter. There are other parameters also, but you need to get the data like retinal detachment also you can work out through ocular ultrasound. Okay, so these three key biomarkers people are working on. Moreover, if you go to the
Is there
another
any
or hello,
brain tumor detection like that?
no, brain tumor detection is totally different. Okay,
Okay, sir.
we can't get because this is an ocular part through the ocular we are getting this ocular ultrasound. For brain we use CT scan or MRI, and brain part differently we get. So that is different thing.
Okay, sir.
Okay, so the main objective here to predict the intracranial pressure, because if you search out, it is very important parameter for trauma patients. Okay, and regular monitoring is must. So what is my idea is in this work that we can't go for CT and MRI. Okay, and we need a
Okay.
very effective tool like ocular ultrasound. Okay, and through ocular ultrasound it is like easily carryable also, and we can easily get the ultrasound image of the eye. And the importance what I need to focus here that you can say that people used to generally having an eye checkup regular ways. Okay, so if we can, because you can see during that examination also when people used to go for eye, people used to get that another pressure, that is the intraocular pressure. You have heard about it, I think. Okay, so eye pressure which is to measure through some instrument is the tachometer. I could not get some name is that like this. Okay, through that we used to put some pressure on like through that, and we measure that pressure. Okay, so this intracranial pressure can also be related, and it will be helpful for some patients like in sports injuries we can say. Okay, or in some accidents, like sometimes in primary cases we don't know what injuries are there, but later on it's move into brain tumor, what you talk about recent just now, brain tumor and other things. Okay, so this pressure used to build up because the CSF fluid used to increase, and then this what I say, this information came where we need to reduce the ICP pressure or other parameters. Okay.
Okay. Thank you, sir.
Okay, sir. So can I leave now?
Okay, sir. Please.
Okay, thank you so much.
Thank you, sir. Thank you very much.
Can exit.
Yes, sir. Yes, sir. Yes, yes. Very good. Okay, no problem, sir. Yes, yes. So good evening all. I welcome you all. Is it audible?
Yes, sir.
Yes, sir, audible.
Is it audible?
Yes, sir.
Is it audible? Nitya?
Yes, sir. Yes, sir.
Screen is visible?
Yes, sir.
Okay. So, good evening, everyone. It's a pleasure to welcome you all today. I, Dr. Praveer Kumar Shetty, and all of you know, we are with the last 2 days, and I'm delighted to have the opportunity to discuss an important emerging area in medical imaging and diagnosis, specifically the application of deep learning techniques in diagnosing common-related cancers. Today, we will explore how the advanced imaging technology are being tailored for breast cancer, ovarian cancer, and that cervical cancer, and how the artificial intelligence, particularly deep learning, is revolutionized that early detection and diagnosis. I will also address some common questions regarding transfer learning, pre-trained network, and use of publicly available dataset, aiming to clarify this concept for everyone. Because from the last 2 days, many of our participants are asking about very means silly questions that what about the pre-trained network and how it is being trained and how it will be deep converted to the deep learning like that. So our discussion will include uh, recent development, proposed future work, and the practical insights that can pave the way for improved diagnostic tools in women's health. Thank you all for being here, and I look forward to an engaging and insightful sessions with available questions and discussions. Okay, so So the thing is that the hormone-related cancer that include the breast, cervical, and that ovarian cancer. Why it is not moving? Yes, uh, cervical cancer and that ovarian, uterine, and vulvar and other type of gynecological cancers. So the thing is that hormone-related cancer are types of cancer that predominantly affect the hormone due to anatomically or hormonal or genetic factors. These cancers may be, I told that breast, yeah, ovarian, yeah, cervical. So, and other cancers are also there, endometrial cancers are there. But we mainly focus on the breast cancer, ovarian cancer, and the cervical cancer. So these cancers are among the leading causes and cancer-related morbidity and mortality in women worldwide. Early detection and treatment significantly improve the survival rates. That's why the different type of the models are being proposed and working, the research working going on. And mostly main thing is that awareness and the screening program are vital components for the women's health, because most of the cases what happen, women are not going to the health center and for the treatment and for the screening process, and also that many of the local or the rural health center that do not have the technical people, or you can medical practitioners available, or you can say the equipments is available. Okay, so because of this also it is not possible. Participant, please mute. So the major types of the hormone-related cancer are the breast cancer, ovarian cancer, cervical cancer, and endometrial cancer, and vaginal or the vulvar cancers. But the major is the breasts, ovarian, and the cervical cancer. So this is the statistics of the hormone-related cancer. So the hormone-related cancer include the breast, cervical, ovarian, uterine, vaginal, vulvar, and other gynecologic cancers. But the statistics says that the breast cancer is the most common cancer in women worldwide. The global incidence in 2020, it is the statistics given up to 2022. So approximately 2.3 million new cases are there. Okay, and the leading cause of the cancer death in women is this one, is the breast cancer, about 68 lakhs 5,000 deaths annually. Then it comes to the next one is the cervical cancer, which the significance in low and middle income country due to limited screening and vaccination. Okay, right now the government is also working for that vaccination process for the cervical cancer. And the global incidence in this case is more about 60 lakhs 4,000 new case, and death is annually 34 lakhs 2,000, like this. Okay, and the cervical cancer is because of due to the HPV, that is a human papillovirus, and it is a if there is it is very risky. So that if there is a vaccination process, then there is reduce the risk. Okay, then another one is the ovarian cancer, that is approximately 24 lakhs 5,000 new cases globally annually, and mortality rate is very high, and more about 1 lakh 93,000 deaths annually. And another one is it is less, that one is the uterine and the endometrial cancer, and then the gynecological cancer, other cancer are there also. But the most significant, or you can say the dangerous cancers are these three, that is breast cancer, cervical cancer, and that one is the ovarian cancer. So the cancer is not only affect to the women only, it also affect to the both the sexes. Okay, men and women also. So as per the global statistics of the cancer, the new cases worldwide, it is in both sexes. Okay, men and women, it is approximately 19.3 million, and cancer death is about 10 million. Okay, so the common cancer in men is the most common is the lung and bronchus, that is about 1.8 million new cases and 1.4 million death case. And next one is in case of the men is that one is the prostate cancer. Okay, that is 1.4 million new cases and most common in case of the men. Then it is colorectal cancer. That one is 1.4 million new cases and 87 lakhs death cases. And the more common cancer in case of the women is the death, is the breast, sorry, the breast, that is the most prevalent cancer. It is about 2.3 million new cases and 48 lakhs 5,000 is death case. And then come to the lung, that is 1.8 million new cases and similar to the men also. And then what it is the colorectal cancer, that is 1.3 million cases. So the lung cancer remain the leading cause in cancer in both the sexes. Okay, but the thing is that, so but in case of use, if as per our focus in this talk, this one is the woman related cancer, then it is the breast cancer, then that one is the ovarian cancer, sorry, cervical cancer, then it is the ovarian cancer. So why the cancer is killing more women than the women? Which type of the cancer are killing more women in case of the man? See, this is the pie chart. Within this pie chart, you can see that the breast is the most of the area, then cervical cancer, then the ovarian cancer, then other cancer. Okay. So in this case, what happened? Cancer generally causes more death in men than women overall. However, specific type of the cancer like breast, cervical, and the ovary, like this, these are more cancer which are mostly women are the affected. Okay. So while very common in women in case of the breast cancer, it is less relevant to the men. And about the cervical and ovarian cancer, it affect only the women. Okay, so their impact is exclusively for the female only. In some regions, particularly cancers unique to women or more prevalent among the women, may result in high mortality rates for the women than men, those specific cancer, like ovarian cervical cancer and the ovarian cancer. So overall, globally, men tend to have high cancer-related mortality rates because of the high rate of the lung, liver, and stomach cancer. But for certain cancers specific to women, like cervical and ovarian cancer, women may experience high mortality relative to those cancers. Okay, so the statistics of the breast cancer and its impact is that breast cancer is the most frequent diagnosed cancer and the leading cause of cancer related to death among the women worldwide. It has significant societal, economical, and health impact globally. So, uh, incident rate in case of the 2.3 million as per the 2020 WHO data, and approximately 24.5% of female cancers are approximately trend. And mortality is, as I told, that it's 6,85,000 annually, and it is among the all these age. Okay, that is up to 50 years and older are more most cases. That means most affected is, that means after the menopause, and increasing incidence in younger women in some regions. So mainly the affected region in world is the North America, Europe, and Australia, and low incidence is the Africa and part of Asia, but rising rapidly. This one. Then come to the ovarian cancer. So ovarian cancer is a significant gynecological malignancy known for its early symptoms and high mortality rate. It often remains undetectable until advanced stage, making it a critical focus for early diagnosis and interventions. So in this case, it is more about 24 lakhs new cases and diagnosed worldwide, and 3% of all cancers is women, but accounts for roughly 5% of female cancer death. Okay, so mortality is more about 1,50,000 annually, and one of the most deadly gynecological cancer due to late stage of deaths, because most of the women are don't know, and they are go to the that diagnosis very late. That's why the mortality rate is increased. Okay, and it is most diagnosed women over the 50 years, particularly after the menopause, and risk with the age is especially at 60. And survival rate is with the overall 5 years survival rate, that is 47%, and yearly, so yearly detection can increase the survival up to 90%. And then cervical cancer. So cervical cancer is the major common health issue worldwide, primarily caused by respiratory infections with the high risk human papillomavirus. Okay, it prevented through vaccination and screening process. So in this case, it is approximately 60 lakhs new cases, and it makes the fourth most common cancer among the women. Mortality rate is 3 lakhs 41,000, and a significant portion of the cases result mortality, especially low resource setting, and age distribution is mostly 35 to 45, and risk increase with age, but it can affect younger women too. And the most of the region, that one is sub-Saharan Africa, South Asia, and parts of the Latin America. So low rate of the high income country due to effective screening and vaccination program. And another, the lowest one is the endometrial cancer. So it is very less affected. Okay, so it is about 4 lakhs 17,000 like this, and mortality rate is 97,000. It is also affected in between the 50 to 70 age of the woman, and rarely the woman under the 40 is affected. It is mostly affected to the America, North America, Europe, and Australia, and low in case of the Asia, Africa. Okay. So trends in women cancer diagnosis. What are the trends going on? The landscape of women's cancer diagnosis is continuously evolving due to advancement in technology, screening program, treatment, and public health initiatives. Tracking these trends helps to identify the challenges and opportunity for improvement, like rising the incidence and shifting the patterns. That means in case of the global increase in incidence due to aging population, lifestyle change, that means obesity and reproduction behaviors, and environmental exposure, and rising, that actually rise the cases of the breast, ovarian, and endometrial cancer generally. And another thing is that changing the age distributions, increasing the diagnosis among the younger women, especially for the breast and cervical cancer driven by genetic and the lifestyle factor. And another factor is the urbanization, that is urban population exhibit a higher rate due to sedentary lifestyle, diet, and reproductive behavior. Okay, that is one cause is the late marriage also. And another key factor is the advances in screening and detection. Improved screening protocols, that means widespread use of mammography, pap smear, and HPV testing as lead to early diagnosis. And implementation of the AI and deep learning enhances accuracy and the speed. And low resource setting, that means expansion of the screening program using that visual approaches, mobile units, that is portable, that diagnostic tools, so that people can afford and easily assess, and risk-based screening strategy, that is utilizing the genetic and the molecular data. And there is also ethical issues. Some people are not going for the for the diagnosis and the screening process. And next one is the impact of technological innovation. That is, we know that the deep learning, AI, automated image analysis for mammogram, ultrasound, cytology, slides increase the detection sensitivity, integration of the multimodal data, improves the predictive model, and a liquid-based, that non-invasive approach, that is liquid biopsy and a molecular diagnostic, a non-invasive method that will detect the tumor DNA and enabling and interventions. And next one is screening and diagnostic challenges. That is significant gap in screening coverage, particularly in the low and middle income country. And despite the progress, many women still present with advanced stage of the cancer, reducing the survival rates. And another one, the cultural and socio-economic barrier. Okay, that is the stigma, lack of awareness, and research content hinder the early detections. That's the major factor. And the future outlook and the trends of the women cancer diagnosis is the integration of the AI and deep learning, that is enhance the screening to predictive analysis, so that it can be easily that means help to the decision support system. And also that is global health initiatives, that WHO goes to eliminate the basically the cervical cancer by vaccination process, and utilizing the big data screening program, optimizing the best regional trends, and also that increase the awareness campaigns targeting younger women, especially for the breast and the cervical cancer. So the traditional diagnostic methods, the traditional diagnostic method is that mammography, ultrasound imaging, and that pap smear uh, test and the biopsy procedure. That these are the different type of imaging techniques are available. Okay. So imaging techniques for the breast, cervical, and the ovarian cancers are the chief. If suppose there is ovarian cancer, suppose there is in case of the ovarian cancer, sorry, breast cancer, there is mammography, ultrasound, MRI, and 3D tomosynthesis is there. And in case of the cervical cancer, that is pap smear, HPV testing, ultrasound, MRI, and ovarian is transvaginal ultrasound, CT scan, MRI, PET, CT, all these things are available. So in case of the that for mammography, it is the primary screening and diagnostic tool. We most often know which tool is that means which imaging technique is used for which purposes. That means that mammography is used only for the that what that for the primary tool. Okay. Please mute. So the primary screening and the diagnostic tool, and it is nothing but a low dose of the X-ray. Okay, and another one is the ultrasound. It evaluates the looms and guided the biopsy and assess the dense breast tissue. All these things can be detected by using the ultrasound and MRI. Okay, it is used in case of the high risk screening. That is when you that is go for the surgical planning, treatment responses like this. And nowadays, that is also another one, the digital breast tomosynthesis, which is giving you the sectional images. Okay, that means there is no overlapping, because in case of the imaging, there is something is that overlapping of the frame, all these things is available, but in this case, it is avoided. And pap smear is nothing but a primary cytological screen. That is primary screening method to detect the precancerous changes. If there is any change on the tissue, then it can be detected. Another one is the HPV testing. That is high risk HPV infection. That is mostly for the cervical cancer. Another one is a colposcopy. That is visual examination of the cervix after applying the acetic acid or the iodine, often with biopsy. And in case of the cervical cancer, also MRI can be used in the advanced stage, but MRI can be used in the advanced stage only. And in case of the ovarian cancer, that is transvaginal ultrasound, that is first line tool for detecting the ovarian masses, or there is something presence of or characterizing the cyst and the tumor. And next one is your pelvic CT scan, that is evaluate the extent of disease spread and staging. And MRI also used in case of the ovarian cancer, that is for the characterization of the complex masses. Okay, especially for the intermediate cases. Okay, and PET-CT is detected metastasis and recurrences in advanced recurrent ovarian cancer. So these are the different of the cancers, that means imaging techniques for the different type of the cancers. You can say the different type of the imaging techniques are tools we are applying with different stage of the cancer with respect to the different cancer. So mammography is a specialized medical imaging technique that use low dose X-ray to visualize the internal structure of the breast. It is standard screening tool for early detection of breast cancer. The purpose of the mammography is to detect the breast cancer at a early and the treatable stage, identify the benign breast conditions, reduce the breast cancer mortality, and it is mostly two types, that is screening mammography and diagnostic mammography. Screening is performed by asymptomatic woman to detect the early signs of the cancer and usually involve two views, that is cranicaudal and the mediolateral oblique view. And in case of the diagnostic mammography, that is conducted when there are symptoms such as lumps, pain, abnormal findings on the screening, includes the additional views of the and targeted imaging. So the advantage of the mammography is to prevent the effective and the reducing the breast cancer mortality, detect the tumor less than 1 centimeter, and it is also non-invasive. That means you do not need any type of the that biopsy process. You do not need to extract any type of the but that tissue or the tumor. for the making the microscopy examinations. Okay. So see, this is the two view of the breast, that is mammography, that is a carniocaudal and the mediolateral oblique view. That carniocaudal is the top down view, and that mediolateral is the angle view, side at 45 degree. So carniocaudal is good to detect the central and the that nipple area lesions. So it is depend upon the which area that the tumor or the cancerous cells is present. According to that, you have to take the view of the mammography images. Okay. So like that, mediolateral oblique is more comprehensive view that captures the tissue and the lesion outer line of the breast. Okay. So advances in the mammography and AI integration, that is digital mapping, improve the image quality and the storage capability. That is also available current days. That is 3D mammography, provide the sectional images. And if we use the deep learning and AI, then automated detection, classification of the lesion, which assist the radiologist, so that it increase the sensitivity, especially in case of the dense breast. See, this the next one is the ultrasound. So in this case, ultrasound can be used for the breast, cervical, and the ovarian. See, in this case, what happened? The left one, this one. So in this case, what happened? This one, the ultrasound images of the breast. So with the there is different densities, like mostly granular tissue. In this case, young women and lactations, and mixed granular fatty, and most common this one, and most fatty tissue, that is older women and adipose, like this. Okay. So with the ultrasound, we can determine the composition of the breast, that is homogeneous fibrogranular heterogeneous tissue or homogeneous flat tissue. Notice that mammographic and ultrasound image are very much alike, like this. Same. See, this one and this one. Okay, ultrasound and the mammography are alike. In young women, the breast mostly contain the granular tissue. This granular tissue can be very pronounced during the pregnancy and the lactations, and can show cyclic changes in premenopausal women, resulting breast that feel lumpy and painful. In older women, it is the granular tissue is gradually replaced by fat, and although some older women still may have a reasonable amount of the granular tissue, in adipose women there is a much more fat in breast, even in case of the younger women. So there is, with respect to the different stages of the hormonal changes, it is very difficult to detect whether with respect to the dense, if it is very dense one, then it is difficult to detect the breast tumor. And another, in this case, we are using also that cervical, or the, what we can say, this one, the normal or the presence of the polyp in case of the cervical, by using the ultrasound, whether this one the normal one and this one here, these polyps are present here. Okay. And in case of the ovarian cancer, you can see that this is the ovarian cancer, whether in this case the tumor is present or not, that can be detected by using the ultrasound. And next one is the MRI. See, in this case, okay, this is the comparison in between the mammogram and the MRI. See, this one is the mammogram, these two, and this one is the MRI. So you can see in this case, it is a dense breast, so that the tumor is not detected in case of the ultrasound, but it is detected in case of the what? That MRI. See, this one the tumor part actually. So a comparison standard that it is clearly showing that in case of the MRI, it is visible. Okay. Similarly, in case if you go for the ovarian cancer, there is different types of the ovarian cancer. Okay, so it is detected by the MRI. That is serocarcinoma. These tumors can be high grade, fast growing, and low grade, that is slow growing. And endometrial carcinoma. This cancer usually endometrial. This one usually grows slowly, but it can be difficult to treat. It's more common among the people with endometriosis. Okay, and another one is the mucinous carcinoma. This tumor grows slowly and most often develop in older men, according to City of Hope, which includes the former Cancer Treatment Center of America. And clear cell carcinoma, that means this kind of the cancer is often cut yearly, which may lead to better outcome more common among the people with which are having the endometriosis. And another test is that one is the pap smear test. The pap smear is also called the pap test. Is a screening procedure used to detect the precancerous and cancerous cell in the cervix, helping to prevent the cervical cancer. So in this case, what happened? It detects the abnormal cervical cells yearly before they develop into cancer, identify the infection or the inflations. So in this case, what happened? The one type of the brush is just putting inside the cervix, and that we are getting that extract the some cells, and that cells will be go for the examination, microscopy examinations. Then it will be diagnosed for this. Another one is the colposcopy test. So, colposcopy test is a diagnostic procedure used to closely examine the cervix, vagina, and the vulva for abnormal cells or lesions that may not be visible with standard examinations. So, when there is any abnormal result in case of the pap smear, then we go for the colposcopy. Okay, so to investigate the abnormal pap smear results to identify the precancer and the cancerous lesions on the cervix, the benefit is in case of the colposcopy is that it enhances the visualization of abnormal cervical tissue, allow target biopsy for a definitive diagnostics, help to determine the severity of cervical lesions. See this one, the that illustration of the colposcopy. Okay, so among the pap smear and the colposcopy, if we compare, the pap smear is the screening test to detect the abnormal cell of the cervical cells, but the colposcopy is the diagnostic procedure to examine the suspicious area directly. That means you can directly hit where the target is. Okay, so from that region only we take the small portion of the tissue or the tumor. So we go for the biopsy. Okay, and it is used for the routine screening, that pap smear, and used for the abnormal pap smear results. When there is any abnormal result in case of pap smear, then go for the colposcopy, and in case the pap smear, that sample collection of the cervical cells using the brush or spatula, and in case of the colposcopy, it is visual examination of the cervix with magnifications, often combined with the biopsy. And if you think about the effectiveness, then effective for the early detection of precancerous in case the pap smear. But the detail allow precise visualization is given by the colposcopy. And pap smear is non-invasive, but colposcopy is slightly invasive. Okay. So, before we go for the research, we must have to know about the what are the different type of the publicly available data sets is present available or not. Okay, so see the publicly available data set for the breast cancer. You see, there is a Wisconsin's diagnosis that breast cancer data set is there available. Another one is Vekis is available, and which is available in the Kaggle. You may not know that the Kaggle is the secondary repository, so there is also in USA. And DDSM, that is digital database for screening mammography, it is also available. And another one is the TCIA, that is the cancer imaging archives, that is also available. Okay, so these are 4 to 5 category of the data sets available, publicly available data set for the breast cancer. And there is the publicly available data set for the cervical cancer. See, there is in IACR, that is International Agency for the Cancer Research, that WHO website, they are also sharing the data set for the cervical cancer. Another Harlov cytology data sets, it is available in the Kaggle. And SPICADMED, that is also available in the IEEE data port. Okay, these are the 3 data sets for the available for the cervical cancer. And for the ovarian cancer, that is again TCIA that share the CT and the MRI images for the ovarian cancer. And for the ovarian mass data set, ultrasound image, that is Kaggle, in available in Kaggle. And if you think about the histopathology, then it is also available in case of the that Kaggle. Okay, so these are different type of the data sets available for the ovarian cancer, that breast cancer, and the cervical cancer. So deep learning for the medical imaging. So deep learning is expected to revolutionize computer-aided diagnosis and image analysis in medicine. Although machine learning has been applied for the computer diagnosis and medical imaging over the 3 decades, clinical adoption has been limited due to limited performance and traditional approach. Recent advancement in deep learning have spurred new efforts to develop the computer diagnosis and AI tools for the various healthcare applications. Numerous studies also going on, and the reporting also that published. So major challenges in case of the clinical integration is the collecting large and diverse database for training and the validations, conducting independent testing with multi-instance dataset to assess the generality. That means because there is in case of the medical imaging, the pattern of the medical imaging is vary with respect to the region to region. Okay, and establishing the performance standard, acceptance testing, quality assurance procedure, and ensuring the model meet clinical requirements and remain consistent over the time, providing adequate user training to help the clinicians understand the AI capabilities and limitations, and developing the interpreted AI outputs to enable informed clinical decision making, addressing workflow efficiency and cost consideration, ensuring AI do not add undue time and expenses without benefits. So effective computer diagnosis tools must align with clinicians' needs, deliver the interval results, and be practical with clinical workflows. That means it should be that the whatever the methodology, algorithms, or the model that developed for the different purposes, that should be integrated with the different type of, or can develop the prototype so that or can integrate with whatever the tools available for the diagnosis of purposes. And another thing is that most have to that how to use these integrated AI integrated tools, that most have to familiar with the that those people who are actually that medical practitioners, those who are working. So they must have to know that what is the advantage and the limitation of these tools. So uh, introduction to deep learning architecture, we must know that there is deep learning architecture have evolved significantly over the time, driven by advancement in research, computational power, and data availability. Initially, simple architecture like perceptron paved the way for the more complex models such as convolutional neural network and recurrent neural network. So introducing that dropout regulation, batch normalization, and the attention mechanism to the model performance. Recent trends it is going on that use of the transformer, rise of transformer, that is natural language processing systems, and the exploration of the hybrid architecture, combining the neural network with symbolic reasoning. Overall, the evolution has been characterized by continuous innovation, leading to increasing the powerful and versatile deep learning architectures. So, see, from the 1943, that electric brain, then it is come for the neural learning in 1949, then 1956, that is Dartmouth, then 1958, that is perceptron, then 1960, it is Adeline, then 1969, it is exert problem. Sorry, then 1974 it is back propagation, then Hopfield network 1982, then 1985 that is Goldwell machine, then multi-line processing in 1986, then LSTM comes in 1997, then 1980 that is linear network, then 2006 that is deep belief network, then 2009 it is deep Boltzmann machine, then 2012 that is AlexNet, then 2014 it is GAN generative adversarial network, then 2015 it is UNET, then 2015 again ResNet, then again 2017 it is the transformer, different type of transfer capsule network actually, then 2018 it is VOTE, then 2020 GPT-3, then 2022 that is stable diffusion, then ChatGPT 2022 again that is ChatGPT 3, 4, then different versions of the ChatGPT coming. Okay, so these are the different timeline to develop the different type of the neural network. Again, with respect to artificial intelligence, that is 1956 that artificial intelligence comes, then 1958 that Franklin proposed the scheme to device that stimulate the process of human brain. Like this, there is in 1997 that is LSTM, then 14 like this. So it is going on. Okay. So the main factor, the key component of the deep neural network is the neuron. Okay, so in this case, what happened? What is neuron actually? Neurons are is the heart of any neural network, including the perceptron. These digital entities receive input, apply the weight, and produce the output. That means what neuron do? Neuron do the taking the input or receive the input, then apply weight here, then produce the output. Neuron are the building block. It is the building block which information is flow from one layer to the another one. That means within the network, it will flow from the one stage to the another stage. Just neuron is just in our brain communicate these fundamental blocks, communicating the language of numbers like that. Okay. So in this case, what happened? There is the major part is the activation function. So activation function, see activation function. Okay, activation function, such it is just like a step function in the perceptron, which determine whether the neuron is fire or not. Okay, in other words, it decides whether the information is flowing is allowed to contribute to the output or not. Okay, so that means it is just like a threshold. If it is incoming data is the above the certain level or not. If it is certain level, then it will fire. That means it produces the output. If it is not, then it is remain silent. So it is just like a binary decision making. Okay. Then there is another thing is the weight and the bias. Weight and the bias. Weight and bias are adjustable parameter. Okay, in the network that influence the importance of the input features and establish a threshold for the activation. Okay, that means these weight and bias help to the activation. Okay, each input data features is given a certain weight, indicating its importance in the decision. And bias act as minimum requirement. Biasing is the minimum requirement for a feature to contribute. Okay, so by adjusting the weight and bias during the model training, refines its ability to make the accurate predictions. Okay. And another some other parameter like loss parameter and the optimizer are also there. So loss function, that means loss function quantify the difference between the predicted output and the actual target. So the objective of the loss function is to minimize the difference during the training process. In the context of the perceptron, the concept of error or loss become evident. Okay, the perceptron learns by reducing the difference between its predictions and the actual target, laying the groundwork for understanding more sophisticated loss functions in advanced neural network. Okay, so in this case, what happened? The mean squared error and cross entropy loss are the example of some loss function common in the different use cases. And another one is the optimizer. So all the more straightforward in the percentile context, optimizer are crucial in adjusting the weight, okay, and the bias. Okay, so weight and bias are depend upon the optimizer, which type of optimizer you are using, and they are computed. Okay, so they fine tune the model parameter to minimize the loss and improve the overall performance. So these are different type of the optimizer like gradient descent, Adam, RMS probe, all these things. So understanding these fundamental deep learning concepts will help us to explore more complex deep learning architecture. If you do not know, yeah, the concept is not clear on the neuron, that bias, weight, activation functions, all these things, perceptron, optimizer, then we can't design a network. Okay, so we must have to familiar with this so that we can explore the deep learning architecture. Okay, so the main thing is the first that we must have to know about the artificial neural network. So artificial neural network in this case serve as the foundation architecture in case of the deep learning. In case of the deep learning, ANN is the foundation architecture. At its core, an ANN is characterized by layers of interconnected nodes comprising the input layer and one input layer and one or more hidden layer and the output layer. Okay, so information flows in unidirectional manner, only unidirectional manner. Okay, progressing from input layer through the hidden layer to generate the final output. Okay, so each node in the network represents a neuron and is connected to nodes in the adjacent layer. These connections are associated with weights. All these connections are associated with weight, which determine the strength of the connections. And the input data is fed into the network, and as it passes through each layer, the weight is summed is computed, weighted sum is computed, and an activation function determines the output of each node. This process continues until the final layer produces the network's output. So next, the backpropagation technique, okay, improves the model performance and accuracy. So backpropagation take a vital role in this case, facilitating the learning by adjusting these weights bias on prediction error. If there is error, then that will be fed to the by through the backpropagation. So input data transfers the network, accumulating the weighted sum at each layer, where activation function govern a node output. The iterative process reaches its peak in the final output, then generating the network output. Okay, so in this way, the NNEs work. So this is the convolutional neural network. So in this case, what happened? It is mostly used for the image classification. So in this case, you can see that there is convolution process is going, there is pooling and the flattening, all these things, and this one the dense layer, and which is nothing but the output layer. So three things is here. One is input, one is hidden, another is output. So what is the advantage in case of the deep learning, or you can say the convolution, that is the main backbone of the deep learning, the convolution network, that in this case there is no need of the feature engineering like the machine learning. In case of the machine learning, there is need of the feature extraction technique and need of the feature selection techniques like this. But in case of the convolution neural network, there is no need of the that feature extraction or the feature selection techniques. It automatically extract the features and pass to the that convol from one layer to convol. Then it will be fed to the or information is passed to the next layer like this through the pooling. Okay. So, as many of the participants are asking about the pretend in the last class, I think, yesterday talk that what is pretend network, how it is to be. So that's why I include this one here. A pretend network is a neural network that has been previously trained on a large data set to perform a specific task, such as image recognition, natural language processing, or the speech recognition. These networks have learned general features from their training data, which can be fine-tuned or adapted for new related tasks, saving time, resource compared to training a model from scratch. Common example is the ImageNet trained convolutional neural network, such as ResNet, BGG, all these things. And ImageNet is a large-scale visual database designed for use of visual object recognition research. Okay, see, this is the ImageNet dataset. So in this case, what happened? Actually, by this dataset only, the all these pretend network are being trained and validated. Okay, so the ImageNet dataset, it is the original ImageNet dataset contains the 70,000 classes derived from WorldNet, that is lexical database. However, the most commonly referenced version is 1000, that is ImageNet 1K version, that is which features 1000 classes that are frequently used for the as benchmark for the deep learning model, particularly CNN, that is convolutional neural network. So these classes, okay. So these classes represents a widely variety of objects like objects, animals, scenes, and other visual concepts. Like another type, that is animal, that is dog, cat, elephant. Object like car, chair, bottle, fruits and vegetables like apple, banana, carrot. Musical instrument, guitar, piano, household items. There is different scenes also you can see here. Okay, so each class has numerous and annotated images, making ImageNet a valuable resource for training and the benchmarking computer vision model. So mostly, so in case of the pretend network, this is the data set where by use of this data set, the model are trained and validated. So don't be confused. So these are different pretend networks which are trained by using the ImageNet data set, that is AlexNet, you can say VGNet, and VGNet have the different versions, that is VG16, VG19, ResNet having ResNet 50, 101, 152, like this. Inception have the Inception V3, Inception ResNet. Again, there is a lightweight model like MobileNet, that is MobileNet V1, V2, V3. DenseNet, that is DenseNet 121, and DenseNet 169.201. EfficientNet having a different version from EfficientNet V0 to V7. That is in case of the NASNet, that is NASNet large, NASNet small, all these things, and in case of the exception, then different type of the that pre-trained model are present or available, that which are actually trained by the image net dataset. Okay, so this is the evolution of the pre-trained network. You can see that AlexNet, SqueezeNet, ShuffleNet, with respect to the that it's a that timing and the accuracy. Okay, they are evolving. That ShuffleNet, GoogleNet, ResNet 18, MobileNet, VGG16, EfficientNet, Inception V3, like national class like this. Okay, so with respect to how much time, that computational time is required, and for a particular that image net data set, and how much accuracy it gives. Okay, with respect to that, these are the evolving different type of the prepared network. Okay, so that if we go for the more detail, that is AlexNet, it comes in 2012, that introduced the deep convolutional neural network with the ReLU acquisition function and data augmentation techniques. Then LeanNet, ZFNet, then deeper architecture comes in 2014 to 17, that is VGGNet. Okay, so there is increasing network depth with the stacking small 3 into 3 convolutions. Then GoogleNet in 2014, then ResNet, it comes to 2015 into the residual connections. Okay, because of the reducing the complexity. Okay, and so again from the 2017 to 20, the advanced and efficient architecture like DenseNet comes in 2017, MobileNet and ShuffleNet, which are focused based mainly for the lightweight model, that which can use or integrate in the low end devices. Again, in 2019, it comes EfficientNet, that is use neural architecture, search balanced network depth with resolution efficiently. And currently, 2020 onwards, that is transformer-based model like vision transformer and hybrid architectures. And these are mainly focused for the research like this. So, what is deep learning? Deep learning model are trained by using the large sets of label data and can often learn features directly from the data without need of any manual feature extraction. So the backbone of the deep learning is the CNN. So a CNN convolves learn features with input data and use the two-dimensional convolution layer, making this architecture well suited for processing 2D data such as images. The CNN works by extracting features directly from the image. These relevant features are learned while the network trains on a collection of images. This automated feature extraction makes deep learning model highly accurate for image classification tasks. So this is the actual architecture of the deep learning model. So what happened in this case, that a convolutional neural network is robust architecture because it is the backbone of the deep learning, robust architecture for image processing and the feature learning and the classification projects. It comprises three essential layers. Okay, and one is the convolution layer, one is the pooling layer, another one the fully connected layer. You might have seen this. Okay, convolution, pooling, and the what fully connected layer. So, convolution layer is the core of the CNN that execute the crucial operation. That means there is some of the filters are used, like a Sobel filter and the fluid filter are used, which are convolved with the image, and then the summed output is fed to the next layer like this. This layer utilizes the kernel, or you can say the filter. Kernel and filter are synonymously used that are to perform the convolution operation, adjusting the horizontal and vertical based on the stride. Stride means how much shift it will be go at a time. Okay, for the convolution process. The convolution layer incorporates the non-linear activation function, that is ReLU, that is rectified linear unit. that mostly used in this case. Okay, and ReLU enhances the network ability to capture the complex pattern by introducing the non-linear. That's why actually ReLU is used. Then comes to the pooling layer. The pooling layer is responsible for the dimensional reductions, minimize the computational requirement while retaining the essential feature. Yes, the two common types of the pooling is that are the maximum pooling and the global pooling, which selects the maximum value in case of the maximum pooling within the kernel area, and in case of the average pooling, it calculates the average value. Okay, in case of the global pooling, that is globally, it will be take the values, and pooling enhances the network robustness and helps manage computational resource efficiently. So mostly actually average pooling and the maximum pooling is used for the image classification. And the last layer is the fully connected layer that is operating on patterned input. Okay, the fully connected layer connects each input to every neuron, initiating the classification process, typically located near the network. That means it is the last end of the network. Okay, and a fully connected layer performs the mathematical operation. That means after that there will be which finalize actually the classification. That means what happened after the fully connected layer? Fully connected layer is nothing but a dense layer. Okay, so after that there is a softmax which actually take the score, that is probability score of the that whatever the test image we have given. Okay, if the probability is as per that sigmoid function, actually probability that softmax is a sigmoid function actually used. If the probability score is high than the other classes, then we gives like that. Okay, so beyond this layer, there is the additional component which contribute to the CNN functionality, that is activation function that influence the classification outcome. And another, I already told that softmax, which ensure for the normalized output, and based on that, the probability will give that predict. And another thing is the dropout layer. And another dropout, sometimes there is dropout is used so that we can reduce the overfitting. Okay, and that nullify the specific neurons contribution and promote the more robust learning across the different training. But the dropout is depend upon the different depend upon the data set what you are using and which type of the network you are being proposed. So transfer learning is, some people are confusing between the transfer learning and deep learning. So that's why I want to clarify that transfer learning is a specified approach of the deep learning. That means transfer learning is not comes first and the deep learning is later, not like that. In a whole, there is deep learning, and from certain approach, transfer learning is there. That means what? Where the pre-trained network is adapted to a new task. That means there is already available pre-trained network like AlexNet, and that VGG 16, yeah, VGG 19, yeah, GoogleNet, Inception, yeah, Exception, whatever the pre-trained network is available. But we are using that network for a new data set. That means previously what happened, that one is trained by the imaginary data set, but we are using by our own data set. Okay, so instead of training the model from this class, the transfer learning levers the knowledge. That means whatever the knowledge that model already gained by using the ImageNet data set, that knowledge is being transferred to our new data set, but it needs some few time fine tuning. Okay, so that it will be perform well. So it leverages the existing learned features, making the train process more efficient, effective, especially when data is new task. Okay, see, this is the example. I'm giving here the example of the transfer learning. See, the top one, this one is the imaginary data set. Okay, so this one is trained by using, this is the designed already the one network, and suppose it is CNN convolutional network A. But what happened? So by this already designed model is used for the ultrasound, that classification of some ultrasound images. Okay. So in this case, what happened? Whatever the parameter, whatever the transfer, everything is being transferred. The knowledge is transferred. So in this case, what happened? You may freeze or not some of the layers according to your requirement. Okay, so in this case, what happens? Suppose there is some classifications there, but in this case, you need only two-way classifications. According to that, you have to change or the modify this net convolution layer or the net layers. Okay, so this is nothing but the change of the hyperparameter, the change of the modification of the layer with the existing network is nothing but the fine tune, and that's why we are saying that the knowledge is being transferred. That's why it is transfer learning. So this is another example. See, in this case, what happened? The imagery data set is used by the AlexNet. It is the AlexNet network. This one is the AlexNet network. This is AlexNet network. So in this case, what happened? This one is used for the ImageNet classification, ImageNet dataset. So as I told that ImageNet dataset is having how much? That is 1000 classes. So it classified 1000 classes. But the thing is that if we are using this one for the what? That polyp classification, that is that is endoscopy, that is polyp, that is colorectal cancer. Okay, polyp classification, whether that is presence of the polyp or not. That means whether it is cancerous or non-cancerous, like that. Okay, so in this case, what in this case that is 1000 classes previously, but in this case it is 2 classes. So what happened? In this case, there is no fuse, there is no freeze, there is no freeze of the any layer. That means whatever the AlexNet is there used for the ImageNet, that same thing is used from the input to, that means from the initial to the last layer. Only the thing is that in the classification layer, it is for the 1000, but it is for the only for the 2. Okay, only this is the change at the last layer, that is fully connected layer. Only the modification is where the fully connected layer, only there is modification that will be modified, so that it is used for the two-way classification whether polyp is present or not in case of cancerous or non-cancerous. Okay, so this is the way how the knowledge or the parameter is being transferred. That's why it is told named as the transfer. Clear? Now come to our research, that is deep feature extractions and fine KNN for enhanced human papillomavirus detections in cervical cancer, a comprehensive analysis for the colposcopy image. And this study introduced a novel method for classification of the SPV, that is human papillomavirus, using colposcopy image, focusing on its potential in diagnosis of cervical cancer, that is the second most malignancy cancer among the women globally, and it addressing a crucial gap in the literature. That is the study that highlights the unexplored territory of the SPP. That means previously there is no study is reported about the SPP based colposcope image classification. So in this case, we are using the efficient net viewing architecture. See, this is the that data set of the colposcope images, that is whether human papillomavirus is positive or negative. In this case, that is human papillomavirus is present. In this case, there is no presence of the SPP. So this data set is actually we collected from the International Agency for Cancer Research, WHO, on our request. So, and it contains the samples in normal saline acetic and acetic with green filter and Lugol iodine. In this study, we are taking only acetic part, not other that Lugol's iodine. Those parts we are not taking. Okay. So in this case, what happened? The detailed data set is originally it is actually 138 and 151 is available. So to make it balanced, we are only taking 138 and 130. Then we are doing the augmentation by left, right, horizontal, and vertical shifting. Then we are doing another type of the augmentation by brightness, contrast, and intensity variation. So by finally we are getting 2760 numbers, and like this number of the what data sets. See, so in this case, what happened? What we are doing actually in this case, we are doing the that this colposcopy image we are taking. Then we pre-process. Pre-process means what? We are resizing, because these are the whatever the available data set, that images. These are different size dimension of the data set. So we are pre-processed that makes which is compatible with the that efficient net, that is 224 into 224 resolution size we are taking. Then we are using the efficient B0 here for the feature extraction. Then whatever the feature is extracted, these are labeled and fed to the KNN for the classification, whether HB positive or HB negative will be extracted. See. So in this is the architecture of the efficient net B0. Okay, this is the architecture of the efficient net B0. You see this one. From this, what happened? From this, that means after global maximum pooling, max pooling, here we are taking the feature. Okay, so I take you to the that where the MATLAB. Okay. See here, is it visible to all?
Yes, sir. Yes, sir.
So
Sir,
suppose,
please zoom it. Little bit zoom it, sir.
madam, actually it is not possible. This much is only possible. So see this one. So I'm telling you that efficient. Okay, see. Sorry. This one is the, see this one. This is the actually the efficient network. See this one. In this case, what happened? It is the efficient net, that is 290 number of the layers. See the input image, as I told you, that 224 into 224. That the width and the what height of the that the image size it can take, and the dimension and the depth is 3. That means it is 3 means RGB, that is red, green, and blue. These things actually. Then there is two-dimensional convolution process, then batch normalization, then sigmoid, then element-wise multiplication, then a group convolution, then natural, then sigmoid, like this. These operation is going on, like this. Okay. So finally, what happened? See here, this is the fully connected layer. Okay, so before fully connected layer, what happened? There is global average pooling is here. Yes or no? So there is a global average pooling. So in my, see here where I am taking, yes, from the global average pooling I am taking the features. Okay, is it okay? So see here, so from this layer I am taking the global average pooling. So how the feature you will be extracted? See here, I am telling you. It takes little bit time. See, so what happened in this case? See here, these are actually the features. See, these are actually the features. So in this case, what happened? How many number of the features? It is 1000 number of the features are there. Okay, because I am here in this model, I am using for just for your purpose, I am using here. I think yes, ResNet 50. So ResNet, I am using here the ResNet 50. That's why it is giving the 1000 number of the features. Okay, so it varies depend upon that network to network. So in this case, what happened? There is 1000 number of features, and see how many number of the images you are using. That means you are using 2580, 2580 number of the images are here. That means these are labeled. How it is labeled? See here. Training level where? Yes. See, these are the label. That means type 1, type 2, type 3. See, this one. Type 2, type 3. So in this case, like this. These are labeled like this. Okay. So in this way, you are labeled, then the feature is extracted, then you are go for the classification purposes like this. So in this way, what happened? These are the performance of the our proposed model that we are using here: the AlexNet, VG16, VG19, ResNet 18, ResNet 50, ResNet 101, ResNet 201, SqueezeNet, Darknet 19, Darknet 53, exception, inception, ResNet V2, V3, ResNet Players, ResNet Mobile, MobileNet V2, VitalNet, ExcelNet, VNet, everything very using. So out of this, that with respect to the different confusion matrix measures that measure, that is that accuracy, sensitivity, specificity, precision, FPR, false positive rate, F1 score, MCC, kappa value, that this efficient net is efficient net V0 gives the better result, and having the less that FPR. So that's why we are going for the that what modification of the efficient net. That means we hybridize the efficient net V0 with the KMM. Okay, so by doing this, we are getting these results. So this is the confusion matrix, and this is the AUC curve. But this is for the validation. That means 80% data is used for validation, and 20 are used for the that for the what testing purposes. This is the confusion matrix for the testing. This is the confusion matrix. Sorry, AUC curve for the of the testing like this. So the results reveal that 99.9% of the accuracy we are getting, and indicating the external classification performance. And till date, that it will, I think, published in 2020. It was, sorry, 21, yet 21, yet 21. So till that, there is no that paper is published with respect to that cervical cancer diagnosis with, that using the SPB. And so that's why we are trying this one, and it is the results. And the next part is the that is cervical transformation zone segmentation, and that classification based on improved inception sensitivity using colposcopy images. In this case, what happened? There is in the transformation zone, which is the region of cervix, columnar cells are continuously converting into squamous cells. The most typical location of the cervix for the development of the aberrant cells in the transformation zone, a region of the transforming cell. So, and in this case, we are using two phase. That is, in one phase, what happened? That whatever the images that captured by the colposcope, that will be segmented. Then after segmentation, we go for the classification. So what happened? This is the anatomical view of the cervix. So there is cross-sectional view and canonical view and the cross-sectional view. So in this case, what it actually the research saying that actually it is instructed by that IACR that you most have to do this research, and have to open access, publicity open access, so the people can know that these things about that how the squamous cell junction. See, actually what happened? The squamous cell junction is change its position. So by changing its position, that whether the cervical cancer is present on which stage it will be, that can be predicted. Okay, this is the main motto of this research. So new, see, the original squamous cell junction is like this. So after that, what happened? It will be shifted from here. It is new. So the transformation zone is which one? So this area, from new, original and new. This one is the transformation zone. So this transformation zone is actually the area of the metaplastic. That means it is actually the cancerous, whether the cancer is present or not, that we can predict from by analysis of this transformation zone. See this more clearly, this visualization, that the squamous epithelium is here. That see this one original and no, that is transformation zone and squamous columnar junction. Okay, this one is the new one, new squamous columnar junction, and this one is the old, that means original one. Okay, so in this case, squamous epithelium and squamous columnar junction, columnar epithelium, and this one is the transformation zone. What I already is that means this one is the actually that the theoretical vision. Okay, visualization. This one is the actual one. So these are the samples of the colposcope image in the cervical region, that is type 1, type 2, and type 3. So with respect to its grade, that means severity. So what happened? Originally, it is having the type 1 is 169 number of the images, 43 type 2, and 80 very less number of the data sets available. So what we do? So by doing the that augmentation technique by different type of the rotation we increase, then again by that pixel based augmentation, that is contrast, that brightness and translation method, all these things we are increasing it. So first thing is that a segmentation. How we do segment? See this one. These are the okay. I'll take you to the MATLAB. How it will work. See this one. Transformation zone. So let's type 1. See this one. Okay. So in this way, it will the it is segmented. That means what happened? Initially, originally we are getting like this. That means what happened? The actual desired area is this one. The actual desired area is this one. So we have to extract that one. So for extracting, we are that using a certain type of the what that this algorithm. Okay, that corpus. So how? So that we are that is extract the different that means separate the channels red, green, and blue first. Then the red channel is extracted. Then the red channel is extracted. Then someone is okay. Red channel is extracted. Then what happened? The cervix is red color in nature. So implementation of the thresholding in the next step. So there is a after that hit and trial method, we think that the 200 the pixel thresholding value is the best one to extract or the ignore or remove the periphery of the cervix. Now detect the big object using that area filter. Okay, there is instruction in case of there is some yes in MATLAB, or it is also available in your Python. So main region central part is extracted, then trace the boundary of the big object, then masking that one, then again we multiplied with the original with the mask one, then we are getting the transformation job. Okay, like this. So this is the snapshot of the different steps of the segmentation transition zone of colposcope image. So in this case, what happened? This is our proposed network. So in this case, what? This one is the improved inception resonant V2 for the transformation zone classification. So in this case, see, there is in case of the that inception resonant V2, there is some stain, and there is inception resonant A, there is a label, sorry, there is one block, and resonant C, A, B, and C. There is okay. So these are the there is what is that is a local reduction block A, reduction block, and B are there. Okay, so we are introducing like this, and from this what happened? We are only from these blocks. That means what? From A, B, and C. Okay, that reduction block A, reduction block B, and reduction block C, we are taking the extracting the features and concatenating it and fed to the SVM. Okay, for the classification purpose. So we are getting this much of the these are the different results with respect to different models here. So you can see the proposed model gives us the results, which is 81.24%, and the sensitivity is 81.24, and that see the FPR is in this case 9.38, and kappa and MCC is like this. So F1 score is 81.68, which is better than the other cases. Okay, so in this way the model is worked, and if you compare with the other one, see means previous work, then see in this case one that is 80 images, but in this case all they are not, that means grading or severity is measured. They are only CIN. Okay, the CIN and the normal cases they are classified or identified. But in our cases, we are using that the classified the type 1, type 2, and type 3. That is with respect to 81.24% of the accuracy. Okay. The next one is the deep picture fusion and azimuth classification for the enhanced pap smear based cervical cancer. In this case, we are using the pap smear images. Okay, that is for the cervical intraepithelial neoplasia, like this. In this case, like that, those researchers are using that neoplasia, central neoplasia intraepithelial. So, in this case, cervical intraepithelial neoplasia, and in this case also we are using this one. Okay, so this one, the data set of this one is extracted from Spicamed and Harlow. Okay, so in this case there is 7 types of the different classes of the cancer, cervical cancer. So it is dyskeratotic, choliocytotic, and that carcinoma, light diplosia, moderate, and severe diplosia. Okay, so these superficial, paravasal, and metaplastic, these are the these three are the normal cases. Okay, so there is totally this type of the classifications we are done. So see, this is the distribution of the data set. So superficial, paravasal, and metaplastic, these are normal. Okay, but the choliocytotic is the abnormal one. So we and dyskeratosis is also abnormal, and these are the superciliar squamous and epithelium, intermedial, and columnar. All these are normal in case of the Harlow dataset. It is in case of the Spicamed datasets. So we that combined both the Spicamed and the Harlow datasets. So what happened? We take all the normal as a one class and abnormal are with different class. Like squamous cell carcinoma different in situ, and keratinized dysplasia, and keratinized dysplasia, and mild. These are different classes, and is choliocytotic and dikeratosis. These are the different classes. That means abnormal are taking as the single classes, and normal, all of the type of the normal are the taken as one normal classes like this. So in this case, what happened? The pap smear image all are extracted like that using the AlexNet. In this case, what happened? There is 3 pretend network we are using. That is AlexNet, SqueezeNet, and the ResNet 50 we are using. That means what happened? We are first testing all these things, all the network, whatever the pretend network are available. So after that these 3 are giving the best results, perform well for the pap smear images. Okay, with respect to that classification. So 7-way classification. Okay, so that what happened? That from AlexNet, that from this fully connected layer, that FC8. Okay, see, I will show you in MATLAB if it possible. Okay. With this one. In this case, what happened? This is the see. In the case of the Alexander, that is 25 number players. See, the input is taken 227 into 3 RGB. So see, in this case, where the fully connected layer is there, see, in this case, this one is one fully connected layer, that is FC6. Another fully connected layer, this one is FC7. Another fully connected layer, that is one is the FC8. So we can extract from FC6, FC7, or FC8 in anywhere. Okay, so in this case, what happened? In this case, we are taking from the FC8. Similarly, same way, that SqueezeNet, that pool 10, and in case of the ResNet 50 from FC1, it is not FC100, it is actually FC1000. Okay, from FC1, it is overlapping, the image is overlapping. So FC1000, we are extracting the feature, then all the features are concatenated, then fed to the SBM. Okay, then fed to the SBM. Then fed to the SBM for the classification, whether it is normal or the abnormal, like this. So with this, what happened? The accuracy of the proposed model, all these things, it is more about 97% something, and that with respect to precision, specificity in F1 score is giving the proposed model is having 97.62%. Okay, like this. So these are the results we're getting. Then the next one is the deep fine canal classification for ovarian cancer subtype using Epsonet winner. So in this case, what happened? See, these are the ovarian cancer dataset. It is UBC Ocean, one publicly available dataset is there. So in this case, what happened? There is 5 distinct ovarian cancer. That is high grade serous carcinoma, that is HGSC, clear cell ovarian carcinoma, that is CC, endometrioid carcinoma, EC, lower grade serous carcinoma, LGSC, and mucinous carcinoma. So these are the 5 types of the carcinoma. So initially, the number of images are that is EC, that is 118, CC carcinoma it is 90, and HC high grade serous carcinoma is 260, and low grade serous carcinoma is 14, and mucinous carcinoma is 41. So after doing augmentation of these things, I improved this number of the images, and then what is the image size, all these things after augmentation, before augmentations of these things. So these are the samples of the that different type of the carcinoma with respect to the rates of the ovarian cancer. So in this case, what happened? In this case, so this is the backbone of the network. So in this case, what happened? After the fully corrected layer, that we are using the fine canyon. Okay. So in this case, that is MB convolution, that is mobile convolutions is used, and that what happened? It gives the results like this. That efficient model with fine canyon, it gives the confusion matrix for the validations and AUC, and this one for the testing, and this one confusion matrix, and this one for the AUC for the that what for the test datasets. Then also we are doing the TPR, FNR, PP, pulse positive ratio, FDR, all these things we are also doing with respect to different classes, and also for validation, and also for the test, and also we are determine that calculate that LR plus, that is likelihood ratio. Why likelihood ratio? Some of the participants are asking about that in the previous lecture, how we may know that the whatever the that proposed model we are proposed model, that one is valid for the diagnostic or not. So the thing is that according to START, there is a guideline, that is standard for reporting diagnostic accuracy studies guideline. As per that, what happened? That if your AUC is in between the 0.9 to 1, that means here whatever the diagnostic proposed model, that one is excellent. If it is 0.8 to 9, that one is good, and if it is 0.7 to 8, that is fair. If it is 0.6 to 7, it is poor. If below that is 5 to 6, below 6, that means here whatever it is fair. The likelihood ratio for positive test results, LR plus, quantifies how much a positive result increases the probability of having disease. So the range of LR plus, if it is that is LR plus is more than 10, greater than 10, that means it indicates that whatever that one is the diagnostic good is good, and conclusive increase of likelihood of disease. If it is in between 5 to 10, it indicates the moderate increase. Okay, and it is 2 to 5, it is small, and negligible in between the 1 to 10. So the higher LR plus, the stronger the evidence of the positive test. Okay, so that's why we determine here the LR plus, that is likelihood ratio. The last one is the automatic classification with concurrence of the deep handcrafted features. So actually time is over. So so in this case, what happened? We're taking the carcinoma of the deep of breast cancer, that is normal, benign, in situ, invasive. So in this case, what happened? We are just concatenating that concatenating the hand-captured feature and the that deep learning features. In this case, what happened? Alexander Vision system and Vision is evaluated, and among that hand-captured feature, HOG, that is histogram gradient, LB linear binary pattern, and Gaussian logarithm concurrence matrix is being extracted. Then whatever they are giving best result, that among that Alexander Vision system, Vision 9, Vision 16 give better result, and among HOG, LBP, and GLCM, LBP gives the better result. Then both are concatenated. Then with respect to the different classifier, the fine canyon gives the better results. So introduce the fine canyon for the classification purposes. So these are the results. So with respect to the confusion matrix and the AUC, and this one is the TPR and FNR and value. All these things with respect to different class, and this is the comparison with the previous work. So it is better than the previous setup. Thank you. Any question, please?
Sir, before fitting the features to the SPM or KNN classifier, you collected the features from AlexNet or all other deep learning models. So
Yes, yes.
individually, the features are selected, then those are merged. So some of the features might be repeated, like
No. It is not like that. You are asking in aspect of that what? In aspect of the machine learning actually. Okay. In case of the machine learning, these things is happened. In case of the machine learning, actually what happened? That you need to extract the features, then that features is being selected like that. But in case of the deep learning, what happened? Actually, deep feature means what? Actually, this is the actual beautification of the deep learning, that no need of the feature selection or the feature extraction technique. It automatically extracts the features. What these features? These features are nothing but the edge, intensity, and broadness of the image. Okay. So like that actually. So then what happened? Those features are being that means I already shown in MATLAB that these are the features in the numerical value also, because when we are doing in the MATLAB, that is matrix value is also that is computed. So and that these are labels. So with respect to that, they are classified. So in case of the, if you go for the deep learning, so main thing is that you need a big data set. Okay. So, but the thing is that how we will overcome that problem. But in case of the medical imaging, you might have seen that in this case there is some actually 40 images, 80 images are there, but give the results. I'm doing all these things I have done already. Okay, but in that case, what happened? You are doing the augmentation technique. So, with respect to why, in case yes, there is also one limitation that what in some extent where on which case you are doing the augmentation, on which case you are not doing the augmentation. Okay, those images where suppose you are that those images which are collected from the microscope. Okay, on that case, what happened? The microscope, the slide may be, the position of the slide may be changed, and again the brightness of the that lens may be changed. So on that case, you can use the brightness or that variation of the brightness and the contrast. By using those, you can that means these are actually known as the pixel based augmentation. Okay, and another one is the position based, that where you are using the flipping, like vertical flipping, horizontal flipping, and some type of the some kind of the rotation like that. Okay, and another thing is that when there is less number of the data set is available, on that case you can do one thing like I am doing that fusion approach. So you can that what actually deep learning work is for the big data set, large dimensional data set. Large dimensional data set means number of images is more and number of features is more. I shown you that 1000 number of the features are in that what vertically, and horizontally there is number of the images are there. But the thing is that what happened if there is less number of the data sets is available, on that case, how you increase the dimension of that feature, the train feature which is extracted. Okay, so on that case, what you are doing, you are suppose you are using the multiple number of the that networks. Okay, from that you can extract the features, then you concatenate it or the fuse those. So on that way, you are that dimension is increased. And another way is that within one layer you extract the like I'm doing the in case of the ResNet. Okay, that from the different that reductions block A, B, like that, take the features. Then we can on that way also. And another way is that from the like suppose in case of the AlexNet, that is FC6 is there, FC7 is there, FC8 is there. So that means there is 3 number of the fully connected layer is there. So on that case, you can use those features by extracting these 3 layers and you merge or concatenate, then you fed to the end of the classifier like that. So these are, so you have to choose on which way you have to enhance or that increase the dimension of the that feature vector actually.
Thank you, sir, for the in-depth explanation.
Thank you. Any other question, please? I think no question. So
Sir,
for
can you, sir, excuse me,
yes, madam.
sir, would you please tell me any link of the public data set for oral cancer?
Yes, oral cancer already available, madam. Oral
Kaggle
cancer
set, Kaggle data set is having number of images are very less, like 200, and other sources I'm not getting
in
actually.
case of the oral cancer. No. Recently, we are doing on oral cancer. Just recently, we submit a paper on oral cancer. Let's see, just I'll show you.
நம்ம பின்னாடி 2 குரூப்பா அது நமக்கு பிடிக்காது. சந்தோஷமா தான் இருக்க மாட்டேங்கிறேன். I can be happy with what I have. போய் அங்கே இருக்கணும்.
Madam, there is available in histopathological image is available.
Yes, histopathology. That is
Yes.
around in hundreds only. I think 200 or 400 within that. But actually, it's, I think 1,000
There
around.
is 500. 500 means cancerous and 450 non-cancerous, like that is available.
It's around 1,000 in Kaggle.
Yes, in Kaggle. And another one is available. Yes, another one is available, but these are not histopathological images. But these are different. Means I have the data set. Oral cancer. There is a data set by AIMS. Yes, huge data set.
Available, sir.
Yes,
Can we
available.
download?
Yes, that is available in where available, I don't know. But I downloaded that one. It is just a minute. Data collection, yes, AIMS Delhi. That is around estimated to 37 lakhs new cases. Yes. Very huge data set this one.
Can we download that huge data set in our next meeting?
You can, no problem.
It will be taking, I think, some GB. So
yes, exactly. It is more about 1.15 GB.
Okay.
You can download
Sir, good evening, sir.
it. Is AIMS data set actually. Okay.
Yes, I'll once again search and explore it. Sir. Thank you.
Okay, thank you. So for today, the session is over. So tomorrow, I think it is 2:30. Okay, the first session is 2:30 because in 2:30 there will be a talk by
2:30.
yes, 2:30 one session, sir.
Good evening, sir.
Tomorrow.
One question, sir.
Yes, sir.
Sir, good evening, sir.
Yes, madam. Tell me.
How to convert the given images into data sets? You have collected some images. How
Yes.
I can convert that images into data set?
No need to convert the image into dataset because whatever we are doing in case of the medical imaging, these
Okay,
are
sir.
doing the image analysis only. Okay, whether it is for the segmentation purpose or for the for the classification, that means identification purpose. So there is no need of the conversion of the this one to the dataset.
So while we are calculating all the things, for example, random forest, we are trying that one same set. So we can we use the Python code and we can able to run that
Madam,
one.
see
So,
one thing, you are staying with this session or not? I am using KNN, I am using the SBM. Yes or no? So on that case, how I am using? Everything is that feature is extracted. That means those features are nothing but in numerical value. You can say those are the data sets, but these are
so
actually not the data sets. These are the
it
deep
is in the
features.
terms of numerical values.
Yes, numerical values, but these are not actual data set. These are the numerical values of the deep features. That means abstracts of the images.
So you are using MATLAB and you have shown that one. So the same thing shall we try in
Yes,
Python?
yes. Python also. You can, no problem.
So can you share the data sets, please?
Dataset means, madam, actually these dataset is these are available. These are actually publicly available. I share. You might have seen that whatever the dataset is available in one slide. I shared already. Okay,
Okay,
I will
sir.
share those. Okay, from that slide you can that you got the link and you can download it.
Oh, we people are belongs to triple E, so nowadays we are learning that all the things. So that is the doubt we are trying that
No,
one.
not problem, madam. Electrical people are not doing that image image
So that's why we are having
because it
more
is very
doubt.
easy. Electrical and electronics. I am also belonging to the electronics. Okay, no problem. Okay, thank you. So tomorrow there is a session at 2 p.m. Yes, 2 p.m. By Pratik Bansal. They are giving the presentation on the synopsis simpleware software. Actually, how the image segmentation is and the image analysis is done by their software. Okay, those they want to actually share. It is actually complimentary session. So kindly join so that you can know how the software is working. They are from the immersive medtech solutions. Thank you.
Sir, the attendance link of the last session
Yes,
is
yes,
not
okay.
shared.
Madam, actually, I am busy here. Okay, so
Yes,
I'll share.
understood.
I'll
Understood.
share. Just a minute. I share in the WhatsApp group. The attendance is shared in the WhatsApp group, please.
Sir, hello sir, can you hear my voice?
Recording stopped.